Wherever there is calcification is loss of enhancement. See this. Wherever there is calcification, you will find signal loss, and that is classical of a chondromyxoid lesion with this good boundaries, scalloping boundaries, no aggressive bone destruction, but it is because of the expansion. It could be chondrosarcoma, it could be chondromyxoid fibroma. You cannot make out on CT, the CT scan or MRI, but could be either of these, which can be made out on histopathology if the if the histopathologist or pathologist is too good. Now see, finally the contrast picture. See this contrast picture. Wherever the lesion is enhancing and wherever the calcification, why I was saying this calcification, why not hemorrhage? Because the calcification never enhances on MRI. And see, this clear cut gives you a diagnosis that this is a calcification in the lesion which has a scalloping margins, enhancement both on T2 as well as contrast, benign, expansile, not eroding anywhere, and it cannot be anything than either chondrosarcoma or chondromyxoid fibroma. And we have a histopathology of a chondromyxoid fibroma. And this lesion, right coming, see this, right coming from the anterior nares, most anteriorly, huge one, presented with huge bleeding, and see where it is going. It has already destroyed the medial wall of the maxilla completely, already pushed the septum to the opposite lateral wall completely, and then see how it is going behind, completely occupying till nasopharynx. So if you see in the lateral part, in the sagittal section, you can see like this.
Yes,
This
sir.
serpentine expulsile lesion with scalloping margins enhanced on T2 as well as contrast with lack of enhancement due to calcification is a chondromyxoid lesion, and that is what this benign chondromyxoid fibroma is. Any questions or any doubts or suggestions?
No, sir.
So this is one, but the next case we have taken. So we have already discussed this. We'll take this after this case. This is the case we have taken now, and see this patient. This is a contrast CT scan of the same patient, which we have taken, which I told you looks like a possible malignant transformation. May not be, maybe, but why I have a doubt? Let me share with you. This is the contrast MRI. What you see is an expansile lesion with widening of the osteometal area, completely occupying right from the maxillary sinus to the nasal cavity, right from see till nasopharynx. It is, protruding in the nasopharynx like a ball. Can you see this?
Yes.
Huge ball in nasopharynx and coming anteriorly, almost unilateral, and coming anteriorly right up to the anterior nares and presented with bleeding.
Yes, sir.
But you can't discriminate on CT scan what it is. So let's see the MRI. See, this is T2 weighted MRI. And what I see on T2 weighted MRI, can you see something like,
Convoluted.
yes, CCP, something like CCP, not very clear, with loss of CCP, and this look could be inverted papilloma because it is enhancing on T2. And what you see on contrast, the final game changing is diffusion.
Diffusion. Yes, sir.
What you see on contrast, see this. See this? With this loss of, enhancement. Loss of enhancement could be because of necrosis, malignant transformation, or anything. But this looks like something coming from the maxillary sinus. See the CCP, if I change the intensity, you can see the faint CCP. Can you?
Yes, sir.
Yes, sir.
Now, why I'm saying that I have a doubt of malignancy? See on the axial, and let me bring up the diffusion. You remember the diffusion picture of the last patient we operated?
Yes, sir.
Hemangioma. There were no restriction, bright.
Totally bright.
Now see, in this particular patient, see this diffusion.
Yes, sir.
This is huge, severe
Huge.
restriction in the diffusion. That gives me a doubt that this could be somewhere changed into malignancy. This looks like malignant transformation here. The lesion, see this is enhancing diffusion, bright on diffusion, no restriction. That is all benign thing. But once something is, you know, showing restriction on diffusion, that gives me a huge suspicion of, see this lesion here, and see on diffusion this part posteriorly, huge restriction. It's not a simple restriction. And if I calculate the diffusion coefficient, this is quite low. See 0.8, below 1 is highly suggestive of malignancy. Highly suggestive. So in this posterior part of the maxillary sinus here, I suspect a malignant transformation, and we are geared up with a frozen backup. And if it turns out to be malignancy, we'll treat it like a malignant lesion. Still, in spite of having doubt, why I kept for endoscopy? Because even if it turns out to be malignant, you can still remove it. See this? Let me show. Yes. See this? It has not gone beyond the confines of the maxilla anywhere. Can you see?
Yes, sir.
It has not entered the orbit anywhere.
Yes,
Even
yes,
if it
yes.
is malignant, it is completely resectable. It has not gone to the skull base, not gone to the orbit. And the
Yeah,
third criteria, it has not gone in the anterior soft tissues. These are the three contraindications for the endoscopic approach if it turns out to be a malignant one. If it goes in the anterior soft tissues, if it invades the orbital soft tissues, it's an indication for exentration then. If it goes on the anterior part, indication for open approach. If it goes intracranial, invading the brain, open approach, obviously.
okay, okay,
So
okay. Ideal
from,
case, good case.
from all three
Very good
criteria,
case, and
it is still very well resectable whether it is malignant or not. And that's why, even if it turns out to be malignant, we will remove it as usual endoscopically. It has all
by Dankers.
good criteria to be removed endoscopically by dankers. Yes, of course, it will require dankers, and in malignancy also. See this luminal component wherever it is not attached doesn't need anything. You simply keep on debriding and go on to the site of attachment, and to reach there, this will require dankers somewhere in the lateral part of the maxilla. And once we find the site of attachment, we'll go around, drill away the underlying bone completely with at least a 5 millimeter margin all around, and in the depth, the complete bone, until we find a normal periosteum or something all around. That will be the goal. Even if it is malignant or not, the treatment is going to remain same.
Sir, Dr. Imtiaz from Kuwait is asking, is there any area of hyperostosis or stenosis that we see in inverted papilloma usually?
Yes, that is a good question. Sometimes you pick up on, CT scan, the signs of hyperosteosis, conical bony projection, or something like, bone destruction to to give you suspicion of a site of attachment.
Yes, sir. Yes.
But I don't see any, reliable thing which is given on CT scan to be suspicious of a site of attachment. I don't see. We tried to see earlier, but we don't see any reliable sign of. If you have a conical bone projection like anything like this, that is quite diagnostic of a site of attachment of papilloma, which is not here. So I don't see that kind. That may not always be present. And
Yes, sir.
let's see intraoperatively how it turns out to be. But surely we'll remove the laminal component, we'll do a dankers, reach the site of attachment, and then radically we'll remove it. So this is the third case. This is inverted papilloma most likely, though still the previous two diagnoses, biopsies could not prove it, a malignancy. And next will be the chondromyxoid fibroma. And then three different anatomy of sinuses cases. One is a huge intersinus septal cell in the frontal, another is a huge frontobular cell, and the third one coming with a visual disturbance with a fungus pressing on the bare optic nerve in the sphenoid. All three
Amazing.
unilateral cases.
Amazing.
Yeah.
Amazing.
Any question or do we go ahead?
Yeah, go ahead.
For those who were not logged in earlier, our next event is on 6th of September. Is a complete external to inner ear surgery by a dream team including Dr. Ashish Bhumkar and Dr. Ashim Desai, wherein from 6th on September 10 o'clock onwards, there will be live surgical demonstration by three of us on various surgeries on ear, right from external ear, atresia, microsia, to middle ear, basics from tympanoplasty, ossiculoplasty, tympanosclerosis, stapes, cholesteatoma, to inner ear, cochlear implant, and some vertigo surgeries, like that.
Show rib cartilage reconstruction for microtia repair. So we'll show the steps of sculpting and the skin pocket and
In
the atresia
microtia,
repair. Yeah, so we'll use the rib cartilage reconstruction.
Sir, kindly show how
yeah,
to
we'd
harvest the
love to
rib
watch.
cartilage in every step of.
Sure. Yeah, we will.
So we'll see this master in action. You know, he is believed to be one of the best in the world for microtia, who does same stage microtia and hearing reconstruction both, with
Both at the
otherwise
same
people
single
do
stage.
not
Yeah.
do. And we are ready to watch him live on 6th of September.
We'll have three parallel OTs, of course, going, and we'll be going
Yeah, in
flipping from
three
one to the
different
other.
theaters. This will be telecasted from three different theaters, from Ashim and Ashim.
So the
And
the most interesting parts of each surgery will be brought to you.
yes, so that we can show almost all cases.
Sir, I recently showed a post-op picture of Ashish sir's microtia case. I couldn't believe that the patient was having any kind of deformity before.
Yeah. Sometimes we only show the good ones. No, that's the good part of social media. You can hide your complication and only show that you're God.
No, sir,
No, you will.
sir, you are amazing, sir. Really.
The live surgery is what makes the the honest expression.
Yes, sir.
Yeah, so we'll show that. Yeah. And if possible, we requested Ashim to show to give a small talk on tympanosclerosis, the way he does it. I think it's very important. I don't think we got a chance too much to discuss tympanosclerosis.
Yes, we would like to know more and more on tympanosclerosis from him.
Yeah.
Yes,
So we
really
are all
Creating the-
set.
You guys should do creating of the neo incus. That's something which Ashim will show you.
Very
How
nice.
it is prepared for a second stage stepidotomy.
We
in
are
a
all
tympanoid.
set. That is our navigation system for us whenever needed.
Okay, Satish, Ashim, and other time we'll take a short break. I have to go for Ganpati Visarjan. I'll come back to you in about 20 minutes. Yeah.
Fine.
Yeah, this is the unprepared, picture of the left side of the nose. Section. And this is the lesion. Are you getting the picture?
Yes, sir. Very clear.
Lalit? So first of all, sections. Yes. I will quickly remove this. Yeah. Yeah, find out. Luminal component. See this?
Yes, sir.
No point in wasting time in this. If you go faster, there will be overall less bleeding. See
So
some
when you
Surgicel placed. Looks like something like Surgicel or something. I am not taking biopsy from here. Not expecting anything, more from here, which can be useful. But section बंद है ना? पानी पानी. Wash. सेक्शन बीच में आ रहा है मेरे. कहाँ गया वो? सेक्शन करना है. See, such a funny lesion.
yes, sir.
Such a funny lesion. Huge one. You don't know what it is. So this luminal component has to be dealt with like this. There is no other way.
Yes, sir.
Get it fast. So I am exposing at the middle meatus region 40 to segregate the rest of the component from the sinus component. Cobblator. Wash कर दे रहे, wash. Yeah, wash. See, this is, I can see certain landmarks coming into picture. Cobblator. The bulla there, this is the middle turbinate, this is the bulla ethmodalis. This is the secretion in the frontal. You saw the opacification in the frontal, and that is what this secretion was.
Yes, sir.
These are all retained secretion because of the blockage of the ventilation and drainage of the sinus. I am improving the visualization by means of cobblator. This is my uncinate.
Yes, sir.
Now, हल्के हाथ से पकड़ा दो. ना कर नहीं रहा यार. See, I want to segregate this luminal component from the sinus component here. पहले जैसे नहीं करना. Just a pack for a while. Pack for a while. Call दूसरा दे. Give me a different one. Just I'm changing the divider. Yes. And in a minute's time, I'll be able to segregate this luminal component from the sinus one. Watch. Wash. Wash. See some attachment on the uncinate here. There is definite attachment on the uncinate. धीरे डाल पाना. And now this luminal component, देख अब चला, has to be disarticulated from the sinus component. See this segregated?
Yes, sir.
See now completely segregated.
Yes, sir.
And we know this one is a huge one behind. I may not be able to get it from here. We will get it from behind,
Yes, sir.
from the oral cavity. Pack the bada. And mouth opener. One more pack. See now the things will be much easier for us. You have ample of space now to work with our equipments inside the nose, and we can deal with rest of the component much better. Yes. Ajay, next under करा दे. देख मेरे को देख. See this huge.
Yes, sir.
Very, very necrotic. The big one. This is the tumor holding forceps. Not complete. You can imagine how big it is. Hello?
Yes, sir.
See this kind of a material. See how this patient was suffering with obstruction. It was
Yes, sir.
hanging down in the oropharynx, literally. Now we'll focus on the lateral part.
Back to part.
Later. Yeah. वॉश भी कर दिया करना. Straight रखे. Now this is the picture of the nose after that.
Yes, sir.
Yes, yes, yes. Remove. Secretion. Okay. So now things are in control. See, just to improve the surface. Okay, give me. Debrider first. 40. See, this is the lesion coming out of the from the lateral side. I hope the picture is good. Hello? Hello?
Yes, sir.
How is the
Picture is
picture
good.
overall?
The picture
Picture
is
is
good.
good.
Slightly blurring in between, but otherwise good.
Blurring. See, now I am going in the maxillary sinus now.
Yes, sir.
See the mucosa.
Yes, sir.
Looks good. There is a lot of necrotic component into it. I could see the attachment over here. Can you see?
Yes, sir.
'70. लिख के लाया कर. Wash. I am with the 70° now.
70.
Hello.
Yes.
Yes, sir.
My God. I can see the mucosal surface behind. Wash. Can you see the mucosal surface behind?
Yes, sir. We
Yes,
can
sir.
see. The surface is looking good.
And here I'm looking for the appropriate area
Area.
to take a biopsy.
Bye. Sir, can this necrotic area also can give appearance of malignancy on MRI?
Not really. This is all necrotic.
Yes.
Necrotic components show lack of enhancement.
Okay.
बड़ा देना यार कुछ लक्ष्य दे दे. See, this is all necrotic component. That's why it was not enhancing.
Enhancing.
Hold this. Yes. Hold this. Yes. His whole entire component is necrotic.
Necrotic. Yes, sir. Yes.
Very funny. Yes. Good. What I want to see is behind. Yes. See the collection.
Yes, sir.
Oh, this collection also is showing diffusion
Necrotic.
restriction. This also shows diffusion restriction. Yeah. Let me pull it. It is coming out.
But someone's mic is on, sir, I think.
So it is coming out easily.
Yes, sir.
I may not have to do anything else.
It looks benign, boss.
Looks benign. It is quite almost completely necrotic. See this?
Yes.
Yes.
Sir, can we do an anterior canine force approach just to see from the anterior?
I will. In case required, a second port rather than doing the dankers.
Yes, sir. Yes,
I will
sir.
prefer to do that.
That will be a good idea.
That will
Yeah,
give a
yeah.
360 view all around.
Always. This is certainly so far not requiring any dankers or anything. Body problem. See this?
Mucosa looks
Quite
healthy.
good.
Muco
Quite
Very
good.
good. Quite good
Yeah.
mucosa.
This is a surprisingly necrotic lesion.
Mucosa looks healthy, boss.
Yeah, there was a lot of collection behind the purulent collection, sort of abscess behind. Do the debrider, and that gives the restriction. See, nasal masses are so funny.
Yes, sir.
You cannot be 100% sure unless you have a histopath.
ऐसे क्रश हो जाएगा ये पूरा इतनी जगह ठीक है वो हाथ में आते ही क्रश हो जाता है
Yeah, take for biopsy. See, such a smooth surface with completely necrosed material, you know.
Yes, sir.
I think it doesn't even need anterior canine fossa approach. A 70-degree
Yes. For the
endoscope
anterior
will-
component, see, there is anterior component,
Yes, sir.
Yes.
and we don't have a good access from this side. This part I will do a mega middle metal enterostomy, and see this area
Wonderful, sir.
was some sort of attachment which I have removed. Don't want to take a chance. See this?
Yes, sir. This it is coming from anterior part. This
Yes.
now.
Yeah, it has come out completely.
Come out completely. Yes, sir. Looking.
There is attachment anteriorly.
Yes, sir. We are.
No, बोले, वो बोले. Force. See, this is the view with a 70 degree.
Wonderful,
Okay.
sir.
And I am putting my this forceps.
Satish,
Yes.
anytime do you use 90-degree telescope?
Pardon?
Anytime do you use 90-degree telescope to see inside maxillary sinus?
90 degree.
Yes, telescope.
Not really. I used that, rotatable telescope earlier,
Okay.
which is from, 10 degree to 120 degree.
But source have 90 degree, blue color.
Not really, not.
Okay.
But there is no, additional advantage of over 70 degree. 70 you can, by rotating the scope, you can make it 90 degree.
Okay. Okay.
I can make 70 degree, 120 degree even by changing a rotation.
Okay.
Yes, out. Now this part, see, it looks like a, in DD, a infected AC polyp. Could it be? Anybody? Could it be an angiomatous polyp or infected AC polyp?
Yes, it can be.
Can be.
It can be because it doesn't look like as a papilloma here, inverted
Now
papilloma as
see
well.
this part. This part we have to remove again
Again,
completely,
yes.
and it is not. See, in spite of the wide opening, it is not so easily accessible. Wide opening, 70 degree, still. So what? Let me show you something, some other approach. Canine fossa. For
So
everyone,
many people,
even in the
Yes,
polyps
yes.
or
sir.
anything, whenever you find difficulty, see where to do and how to do. See, this is the canine fossa, sublabial.
Yes,
Yes.
sir.
Hello?
Lateral.
Go in the
Yes,
mid
yes.
pupillary line. Let me show you. उसको कर, उठा. Can you see the pupil?
Yes.
This is 70 degree. This is pupil. Yes, अब यहाँ करो. वो ले लो बेटा. Stay in the mid pupillary line a centimeter above the gingival sulcus. उठा नरेश. सब कुछ है दिमाग छोड़. Stay in the mid pupillary line a centimeter above the gingival sulcus. Hold it. छोड़ दे. This is the site. And
So we are
there,
not getting the picture.
pardon?
So we are not getting the picture properly. We are not. The camera is moving to.
कैमरा लगा ना. See, I am in the maxillary sinus. दिखा था ना यार, क्या कर रहे हैं? See, this is my point. Can you see?
Yes,
Yes,
A
sir. Now we can
centimeter
see.
above the, gingival sulcus in the mid pupillary line. And see from inside now where I am. Can you see?
Yes,
Yes.
sir.
Yes.
I am right in the
So this
maxillary
is.
sinus.
So this is
Now,
trocar. Which instrument you have?
now I will not use the trocar or cannula, anything. Remove the cannula, including cannula. So see now my debrider coming from here. Wash कर दे यार.
Yes, sir. Now we can see. Wonderful.
Section भी करो. Section wash. See now my debrider coming from here, and now with the 70 degree vision. बेकार दिया यार. खोल के दे. I will put the debrider got clogged. I'll put that again. खोल के देना चाहिए ना. See now in the maxillary sinus. That was one of the site of attachment. पानी डालो. One of the sites of attachment over here. And we have to ensure that everywhere. See, this blade can rotate. This is red 40 and can rotate into every nook and corner of the maxillary sinus with much ease. See the ease. The blade is spoiled because of this oozing here. The telescope. See the maxillary sinus completely now?
Yes, yes.
Coblator. Let me, get this oozing under control and see everything under vision. Everything under vision. Just 2 minutes. See, this oozing was spoiling the telescope.
Yes, sir.
That oozing. See, this oozing was spoiling. Yes. One more, one more. ये दे count वाला बड़ा. Now I will see into the maxillary sinus once again. Wash. Wash. Still. Yeah. Touch. Touch. This was spoiling the telescope again and again. Yes. No, it is much better. That was the huge nasopharyngeal component this patient had. Now, इधर से डालो. Now, what I will do, I will use this suction cautery from the canine fossa. Can you see this?
Yes,
Hello?
yes. Yes, yes, seen.
And see now what I am doing. Coagulate. Toggle it. दूसरा दे पहले क्यों नहीं दिया now sorry yes now पानी डाल दिया करते थे बेटा yes good job Naresh yes
This is a beautiful demonstration of how you can put your instrument from the canine fossa and use them efficiently. Very nice. This is
this
step.
opening is just 4 mm sir
Yeah, very fun. We used to do it a lot earlier, but nowadays somehow I have
and it
stopped.
doesn't lead
But
to
I
any
think I'll restart it now again after seeing your.
it doesn't lead to any problems later on
Doesn't lead to any problem. Very
yes
simple.
wash now give me just there's nothing
I have revisited
I
this
don't
surgery
see
again.
any problematic pathology here. It's a simple situation, necrotic, surprisingly necrotic. The patient presented with bleeding, with the huge features, and but that restriction was because of the necrosis. That is
Yes.
another feature. The necrosis can give on diffusion. Wash करके पैक कर देना. We'll wash it and pack it, though we have sent for histopathology, but I don't expect anything bad on histopathology for this patient.
Yeah, mucosa and everything is looking normal.
Agreed?
Agreed.
So that's a complete picture of the maxillary sinus from inside. Pack कर देना. Pack it.
So let's move to the another case.
Yes, directly. That
Directly.
we have already discussed the
Yeah.
scan of that patient.
Yes.
That is a so you quickly the MRI and the CT. That was the lesion. And here fortunately we have a good confirmed biopsy. In nasal masses, this is the biggest problem of not knowing the histopathology. You can predict most of the time. See, this is the patient now which we are taking up with this kind of a expensile lesion with scalloping margins and calcification inside, and right from the again from the anterior nares to the nasopharynx. Completely. This is all secretions all around, which is because of the blockage of the sinuses. There is nothing in the critical area. See blockage in the frontal recess. Here the frontal recess, blockage towards above the lesion at the skull base, blockage all around the periphery in the maxillary sinus, orbit, everything intact, just pushing the septum opposite side, which should be, I hope, a straightforward situation. I don't know how much bleeding it is going to give, but it should be a good straightforward situation. Anything? Any question, Udbhav? Or any?
No, sir. Sir, Dr. John Shadows saying that he's been following you all the time on YouTube and he's highly mesmerized with all your surgeries.
Wow. Thank you,
And
man.
same Dr. Talat, Dr. Oli, many people are appreciating, sir. Wonderful discussion. Sir, what to do about the canine fossa opening? Anything we need to do that opening that we have make, or it will heal itself?
See, that is a puncture in the mucosa. It seals on its own in a day or two.
Okay.
You don't have to do anything. Let it fall back. It seals on its own. It doesn't give any, complication.
Before
So
complication.
through this opening we made with a trocar and cannula, You can directly put your debrider 40, red 43 through it, and you can somersault the entire debrider inside the maxillary sinus to reach everywhere. You can reach 360-degree into maxillary sinus with a visualization from 70-degree through the nose. And the debrider coming from the canine
Fine.
fossa. You can have a good 360 access in the maxillary sinus. So next case is ready, and it's a fresh learner. Fresh learner. Fresh. Mukti. इसकी जरूरत नहीं. Next man. Hello. 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 Hello.
Hello.
Yeah, Satish.
Are you getting the picture, boss?
Carefully, मैं मीटिंग में हूँ. तुम बार बार कॉल कर रहे हो. मैं बोल रहा हूँ मैं मीटिंग में हूँ. तुम बार बार कॉल पे कॉल किए जा रहे हो.
Boss, are you
क्या हुआ
getting the
बताओ.
picture? Boss,
Yes, Satish.
are you getting the picture?
Yeah, we got the picture now.
Endoscopic.
Endoscopic. You're
See,
indicating.
this was the packing in place.
Yeah,
And the patient had a bleeding.
right.
See, some secondary infection, bleeding, and this kind of a lesion.
Yeah.
Is it a Vaseline pack?
Pardon?
Is it a Vaseline?
Ointment pack, simple ointment pack, debrider. And see this lesions with calcification in it.
Right.
Expansile lesion. This is, I believe, to be a straightforward situation.
Yes.
See, this is inherent calcification inside.
Wow. Okay.
This is to give an idea that kind of variety of nasal masses can present with bleeding.
Right.
There are n numbers of. We will show later some more varieties. See this?
Yes.
I don't know how the vascularity comes to them so much. साफ कर.
Would you consider using a coablator to kind of truncate the mass?
I will. I am not using cobblator for the fear of ruining the vein because of calcification.
Okay.
I will truncate with the debrider only, boss. Let it be little bit of the oozing. See how important is suction backup.
Yes.
The debrider should not get blocked so frequently.
Your suction is
Yes,
amazing,
sir.
boss. You're using central suction or there's some particular suction you're using?
This is a high power tailor-made suction. Not presently. We have a central also. See, this is one of the attachment there.
Yeah.
So what is the power of this section which you have tailor made?
1.5 HP.
1.5 HP.
Will you take more mass for biopsy?
Yes.
Mr.
Now,
Patel?
now from inside I will take.
Okay.
Code luck code. Flux there. Suction. Suction. Wash. Wash this. Did हल्के हाथ से. Yes. See this.
Wow.
Yes, sir. Huge comp. Huge.
I think it is out.
Out.
Yeah. Watch. देख नहीं दिया करना. धीरे. यो. हल्का हल्का. That is the nasopharynx behind.
Yes, sir.
Oh.
Now another pull.
Was it a previously operated patient?
What is that?
Was it previously operated?
Pardon, boss? Can you repeat?
He's asking if it was previously operated.
Not biopsy was taken.
Because I can see a very large MMA.
Yeah, it is because of this mass lesion.
Okay.
Because of its expansile nature, we saw on scan. That is simply because of its expansile nature. See this? I am trying to pull out as a whole. But it is friable. It breaks. देखने दो यार. हल्के हाथ से खेलते हैं. ये देख. Again a huge one. I want to remove it as a whole for the pull. may come, may come, may come, may come.
अरे इसको बंद करो.
See, somewhere attached over here. See that?
Yes.
Now. Now. Now give me. Was it a nasolacrimal duct? Look now. Can you see the NLD?
Yes.
Yes, yes, yes.
Oh my God, unbelievable. Unbelievable. So somewhere it is attached to the NLD. Cobblator. I will use 70° after just cobblating this surface. See, the NLD was out, the lesion was attached to NLD.
So are you going to cut the nasolacrimal duct flush?
Yes, that is what we are doing now.
Yeah.
It should not be hanging like this.
Not be hanging, otherwise it will stenose.
Cowdlip. See now. This will be much fixed above now.
Yes, sir.
See this?
Yes.
Yes.
See the duct, 70. Now, a little bit component or some collection or whatever inside. That's it. Clean करना था.
In this case, considering the attachment to the mucosa of the inferior turbinate, will you be cutting or removing all of that bone?
Yeah, it looks fine now.
Okay.
I removed with the last part where the NLD was there now.
Yeah, yeah.
Cobblator. Divider. Now some see, so funny lesion. This is just secretion.
Yeah.
This is with 70°.
Yes, sir.
Next.
Satish,
Yes.
will you drill the bone?
I don't feel like, boss. There's a. Let me see. I will mop the entire surface.
Okay. Lot of irregularities on the bone.
Yes, yes, I can see. But looking at the histology, this doesn't warrant. This is a very, very, slow growing, safe tumor, benign tumor. But yes, this patchy destruction of the bone I can see. Yeah, I will see in case I feel like. No. No. Cobbletter. ये लगा दो, ये लगा दो. See this vessel here?
Yes, sir.
Yes, that is cauterized, number 1. I'm mopping with the marrow cell all inside. If something warrants, we'll go ahead. See, the rest of the maxillary sinus looks fine.
Yes, sir.
Only this area with some bony projection. See that?
Yes.
वो 60 वाली. This particular area has little bit of the bony projection, which is not looking nice. And
Yes.
when this much of the excess we have, it will, it won't take more than 2 minutes to drill away that. Why to take a chance?
Yes, sir.
See, mopping. Wash. Give me, मेरे को दे wash. Section कर. Now I'll give a thorough wash to the inside of the maxillary sinus.
Cleared है क्या?
See this bony projection.
Yes, we can make out.
Yeah, that is the only area which is not looking good. Rest of the things are fine. एक मिनट तू रुक जाए 2 मिनट. एक मिनट मेरे को आरपीएम चेंज करने दे. कैन यू चेंज टू 12,000? Yes. So I'm using an angle drill. Hello?
Hello.
Yes,
Yeah.
we can see. Yeah.
Yeah. This is we have 2 options. I have to use this 60-degree angle drill. If it doesn't work out, funny.
You can go through the canine fossa also.
Yes. Then our option is to go through the canal fossa. This drill being used at a 12,000 RPM. That is certainly a hyperosteosis of the bone here. No doubt about it. Why
Yes, sir.
इतनी देर हो गई? Give me wash. Better I should go by canine fossa.
Yes. That should be
Regular
better.
drill there. Hello? Yes, show with the.
All this webinar people
दिखना
were
चाहिए.
asking for canine force approach, and now we are back to canine force approach.
So in the mid pupillary line, where the anterior wall of the maxilla is supposed to be the thinnest one, see on a slightest, you don't need a pressure, it is in. That is the area where the हटा देना. Anterior wall of the maxilla is thinnest.
Yes.
Okay. Now see this canine fossa opening.
Yes, yes, yes.
Yes.
See this, and now
Yes.
we will come with a instrument from that side. Yes. Section दो. ध्यान दो यार. See now the ease. इसको spoil मत करो. धार बना. See, my burr is coming from the canine fossa. पानी डाल. See now the bone is good.
Yes, yes. Job done.
Yes.
This ease would not come without a canine fossa. So whenever you feel like, don't think twice. Section. Cord section, long cord. Wash. Now we'll give it a complete wash. Let me show you. Section. Now the final picture I am going to show you. See the bad bone.
Yes, sir.
And now what lastly I am going to do is, can you see this mucosa?
Yes.
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 Not looking good.
Unhealthy mucosa.
Yeah. Chal. This is it. Patla. I have to remove this mucosa and cauterize it as well. Doesn't look nice.
Yes, sir.
उठा दे यार. See, just close to the canine fossa opening.
Very nice, sir.
Yes, now.
So many people were waiting to see this, and now they have seen back-to-back two cases. So people will be very happy.
See, now the surface is good. Look there.
Yes, yes, sir.
Absolutely fine now. Now wash. Now the final picture. See this. This is drilled area.
Beautiful,
This is the
beautiful.
maxillary sinus.
So now the bone is looking very healthy. Everything is looking good.
Dr. Ilasami, you do a lot of maxillary sinus work. You have published.
Yes, thank you.
Anything else you do?
For this case, I think this is the best for this case.
Great. So finally, ये
Ahila sir is a YouTube star. Sir is a YouTube star. We have been following Ahila sir since so many years.
Thank you.
Sir. See, this is the retained secretion above in the recess.
The packets of secretions are coming from everywhere.
Yeah, they will come. You don't need to do anything.
And sir, I think Ahila sir was exclusively rhinology surgeon for 10 years. I think, sir, I've heard you saying somewhere that for 10 years you did only rhinology work.
Mostly.
Now, lastly, mopping of the sinus to see. Mopping with suction. This gives you a very good picture after that. See that?
Yes, sir, wonderful.
इसको wash करके pack कर देना. We'll just wash it for a minute and pack it. हो देना.
So the take home message is that everything has to be seen and then we have to go about it.
Touch. That's it. So this mopping gives you a very good picture inside. If something more is required to be done. There was a oozer which we have cauterized, and that's the full-blown picture of the maxillary sinus now.
Satish,
So will you leave any pack inside the sinus and then we'll take it out after 2-3 days?
Yeah. We'll remove it tomorrow.
Tomorrow.
Tonight we will keep definitely.
Satish, just show the infraorbital nerve for the beginners.
Infraorbital now, yes.
Groove, yeah.
In the roof, we have been seeing in our previous courses, this projection, this bulge.
Yes.
That in the roof is the infraorbital now. We have
Yes,
seen
sir,
in
very nice.
cases the entire course of the V2, which continues as an infraorbital. Pack kar dena. So this was about this situation, all funny situations. There are variety of such, nasal masses. We come in our practice, we come across, and the next one. Hello?
Yes.
So next one is a interesting one in the sense, as we mentioned in the invite, that some regular FES cases. There's always been a pressure to keep the basic cases. So like this time again, some sinus cases. This lady, are you getting the picture?
Yes, we are getting the CT picture.
Okay. If I show you this CT scan from the beginning, one can easily miss what is great in this. See the left-sided frontal sinusitis. Can you see?
Yes.
Left-sided frontal sinusitis. As you come behind, this is the frontal drainage pathway. And as you go behind, now see, until now there was nothing. In the drainage pathway was a cell. Can you see this?
Yes.
In the posterior part of the frontal recess, a cell is appearing. In the anterior part, there was nothing.
It could be a frontabullar cell.
Yes. So that is what. In the anterior part, there are certain group of cells which narrow your frontal recess outflow. Like we have always been seeing, you see on the opposite side. You see on the opposite side.
Sandeep's phone is on. Somebody is speaking from there.
This is Agar Neji. On the opposite side, the anterior cell is agar neji.
Yes,
But
yes.
as you go posteriorly, this cell is appearing. Let me show on other window settings. Better one. Yes, this could be a better one. See this cell. I hope it is visible. This cell.
Yes, yes, yes.
Yes.
So
Yes.
there are anterior group of cells like Agarneji, frontal cell, type 1 frontal cell, type 2, type 3, type 4. We have seen all variety of frontal cells in our webinars. Then there are posterior group of cells. We have seen a couple of them like supraorbital cell we have seen couple of times. And the next one, most interesting, is the frontobular cell. See this? The bulloethmoidal is extending into the frontal recess, sometime in the frontal sinus. Now, what is the difference? Why we need to be so concerned about it? You know? Why we are so concerned about it? The reason is the anterior group of cells, you can go behind and fracture them out anteriorly. But these posterior group of cells, which are attached to the skull base, you can't afford to go behind and fracture them. You will be right into the skull base, damaging through that. So this, let me show in 3D. This is the cell on coronal. Can you see this?
Yes,
Yes,
yes.
sir. Yes, yes.
And where is this cell in the sagittal? Sagittal differentiate whether it is anterior cell or posterior cell. See this cell. Can you see
Yes.
this?
Yes, sir.
Frontobular
Yes.
cell.
Had there been anterior cell any, type 1, 2, 3, 4 frontal Agarneji, we can go behind and fracture them out easily.
Wonderful, sir. Yes.
In this cell, if you try to go behind, you will breach the skull base.
Skull base.
So see now how it has narrowed the frontal outflow.
Yes.
We can't go behind this cell. We are coming from anterior. We have to go onto the wall of the cell and open it. Got my point?
Yes, sir.
That is
Very,
the basic-
very clear.
That is the basic difference, and how the sagittal can clearly differentiate from the anterior group of cells to the posterior group of cells. Is that very clear?
Very clear, sir.
This is a frontobular cell, and the treatment of this cell can be done best when you know it. Now we know it, we will never go behind this cell. We'll come with our endoscope. From here, we'll go into the anterior wall of the cell, and then we'll open it and flush with the skull base.
Yes, sir.
So when we open it and remove this wall and flush with the skull base, our frontal outflow will be completely widened.
Widened.
That is why, as a variety, I kept this case in the webinar. We have seen
sir.
already 7, 8 FES cases, but this has something different, so we kept it. So this, in this situation, your navigation system can be very useful. Navigation system has the biggest role in frontal sinus pathologies, difficult frontal sinus pathologies, in revision situations, when there is a lot of scarring and difficult to identify the structures, navigation is useful. And here navigation has a huge role by locating this cell on navigation and then open it from front. If you
Yes,
are
sir.
if you are not in place and open something else, can be a disaster. So this is the cell here. This is the cell here and this is the cell there. You can see in both planes. Can you?
Yes, sir. Sir, is there any supraorbital cell in this case?
Yes. How can you identify supraorbital? I mentioned in the last webinar, if you remember.
Yes, sir.
See, if you come from anteriorly, this is your nasal bone.
Yes.
Go behind, this is your beak.
Yes.
Beak is forming the floor of the frontal sinus. You can see.
Yes, sir.
This is what we remove in the draft. Remove the beak and frontal will open directly in the nasal cavity.
Right.
Marsupializing. Now,
Yes,
as
sir.
you go behind, the frontal is not draining because the beak is there in the floor. Where do the frontal sinus drain? See this in
Behind.
the sagittal, where the beak ends.
Ends.
See now I am going behind. See now I am going behind, and now the beak is completely gone.
Gone.
See that? And
Yes,
this
sir.
is the frontal outflow starting. So this
Yes.
is frontal sinus outflow starting from behind where the beak ends. That's the posterior most part of the frontal sinus. You see in sagittal, from anterior to posterior, this is the posterior most part where the frontal sinus drains through.
Yes, sir.
And this is the beginning of the frontal recess. Now see in the center what is coming up. This is the cribriform plate coming.
Yes.
Now the frontal sinus is ended and the cribriform, which form the roof of the ethmoid, has begun. Can you see
Yes.
very clear?
Yes, sir.
When the
Yes.
cribriform has begun, your frontal sinus is over.
Over.
You have left anteriorly the frontal sinus. Now you are behind the frontal sinus. And what is there behind the frontal sinus? There are two structures looking like frontal sinus. Can you see this?
Yes, sir.
These
Yes.
are above the orbit. This is orbit. And
Yes.
this pneumatization is going far laterally above the orbit. This is known as supraorbital cell.
Very clearly shown, sir. Thank
Very
you.
clear?
Yes.
See,
Yes,
so
yes.
far behind where the cribriform has started, where the maxillary sinus has come in view, frontal is left far anteriorly. See the frontal sinus.
Yes, sir.
If I draw a line from anterior to posterior, we are far behind the frontal now.
Yes.
And what you see here is the frontobular cell, and that is going to the supraorbital recess, narrowing the axis of the frontal outflow. That is a classical example of a frontobular cell. One can see. Very clear.
Sir, sir, taking this cell out will open both frontal sinus as well as supraorbital
Yes, completely.
Completely.
That is our goal.
goal.
Rest in this patient. There is hardly anything. There is a simple, see the opposite side is normal, unilateral disease.
Yes.
That the maxillary sinus, the ethmoids are opacified, nothing, significant anatomy. Some, osteitis there. There's a post-ethmoidal roof. And sphenoid sinus with a septation looking like a onody cell. And there's a unilateral disease.
Yes, sir.
In all unilateral cases, you have to be suspicious of fungal disease. You have to be suspicious of fungal disease always.
Yes, sir.
Let me show if there is some fungus or not.
Sir, on plain city, only way to know fungus is there or not is hyper and hyper dense shadows.
Yes.
Otherwise, we cannot identify on plain city.
Yeah, it is always better to be seen on soft tissue window setting.
Okay, okay.
Then you can differentiate between the soft tissues.
Yes.
In bone window setting, you may not. Why it is not opening? अच्छा सीढ़ी से चल रहा है क्या? See, this is soft tissue window setting.
Yes.
Let it open. See how many files there? 819 remaining.
Yes, sir.
This is 0.7 mm, 1.5 mm, 1 mm. I am just exploring the soft tissue window to rule out any fungal disease. Though it is not going to make any difference. There is a plain sinusitis. Navigation ready? Yeah. Oh, next.
Sir, I feel in near future you will be getting many head and neck radiology fellow who are doing radiology in head and neck will be coming to learn this art.
Oh. See some hyperdensities I can see inside the maxillary sinus. You can see.
Yes, sir.
I am not sure this is classical of AFRS or not, but there is definitely something. In a unilateral disease, we always suspect. Yes, it looks like fungus inside. Can you see?
Yes, sir. Now we can see.
Last
Yes.
time we saw 3 massive fungus cases. See this
Yes.
hyperdensities. Can you see this? This
Yes.
is
Yes.
definitely fungus. So this is again going to be AFRS. The next case again is a fungus with visual disturbances, unilateral disease. उसको ले लो, विकास. Okay, next is the intersinus septal cell. And this is
Okay.
definitely fungus. Fungus even in the, onodi cell.
Onodi cell.
Yes, fungus everywhere. There's small lateral recess as well. And see this in the ethmoids, this is all fungal disease and the polyps coming out, fungus everywhere. So this is a clear-cut case of a fungal disease. And this is a unilateral case, hope to be um, uh, getting over soon.
Yes, sir.
Hello?
So this is 20 minutes of, I believe.
I will check the accuracy. I will check the accuracy. Yeah. Not moving.
Jaipur team just on a camera or at least any video. Now we are getting only
There is
black.
no picture on the screen. Okay.
In a minute's time, we are starting. Yes.
Still no picture.
Yeah. Now ready. Suno, jodo. Hello. Hello.
Yes.
Yes, sir. Yes. Yes.
Are you getting the picture?
Yes, sir. Very clear.
Yes.
Getting it.
Very clear. And see what is this fungus.
Fungus.
Yeah. Can you focus on the Ajay? Can you ask them
Yes,
to focus
now
on the
we are getting the
navigation
picture.
screen? Okay, give me the navigation probe. Okay, later. Okay, give me 0. Straight. Hello. So we'll
Yes,
start
sir.
with debridement of the polyps.
Yeah, hello.
We have not placed any, topical solution. This is our first preparation. We rely mostly on the pulse and the pre-op preparation. Never inject. Never inject in the nose for anything, sinusitis or non-sinusitis. Just topical. This is preparation with the adrenaline soaked marrow cell. Let us start straight away. See, this is almost without preparation. See, lot of polyps. Polyps over the turbinate as well.
Yes, sir.
And some polyps medial to the turbinate also. See this?
Yes, sir. But sir, as soon as you start your debrider, it looks like someone has fast forwarded the video and it's moving very fast. Your debrider sucks
So,
polyps so
yeah,
fast.
yeah. I will go fast without wasting time here. On. See the fungus.
Yes.
We have seen the basic steps of sinus surgery couple of times. Yeah. Can you show me the yes, yes, section rakna. Now can you focus on the navigation screen please? Section kar. ये ना ना ठीक. Hello,
Yes, sir.
are you getting the navigation screen?
We are getting it.
See now like I am on the septum. You've seen all three planes. I am at the axilla. Can you see?
Yes. Yes.
See everywhere the frontal process of axilla.
Yes, sir.
Then this looks like the part of the bulla. The medial
Yes.
orbital wall. This looks like medial orbital wall. See the accuracy.
Excellent, sir.
This is inferior turbinate. Let me show. This is inferior turbinate. See the inferior turbinate on the axial.
Yes. Yes, sir.
So the navigation should be accurate, and I am so dependent on this sometime when we use the Medtronic navigation system. It's amazing. This is electromagnetic system. The other one comes is with the camera system. This is more versatile as it has a fusion ability. See, every time after every step, wash and mop with the same adrenaline soaked marrow cell. See this?
Yes, sir.
The picture is good.
Very good.
This is, we started almost without preparation.
Sir, can you enlarge the picture?
Now, the previous one. Change to the camera.
Yes, sir. Now it's fine.
Now, looking to the various landmarks, to me, this looks like your uncinate process. See, this is compressed.
Yes, sir.
See this? That is uncinate process, which is compressed because of the polyp mass. Can you see?
Yes, yes.
See how it distorts the picture. The polyps can easily distort the anatomy.
Yes, sir.
You have to be careful.
So you have many times explained the only mobile structure in the lateral wall is
Yes.
infinite.
See how mobile it is?
Yes, sir.
We picked up. This is the bone of the uncinate.
Yes.
Yes. And see behind is going to be that is the horizontal part of the uncinate.
Uncinate.
And that is the interior of the maxillary sinus. See that?
Sign.
A lot of fungus inside.
Yes, sir.
Some mucosal edema.
So Dr. Prakash Munka wants to know in which cases navigation is must.
It's very useful. I can't say must, that I can't comment, but yes, it is definitely useful
It's useful.
because it orients you better to a difficult anatomy. You can make sure, if you are in doubt, that whether you are going correct or not. This looks like to me is an atrophic bulla,
Bula. Yes, sir.
because once there is massive polyposis, everything is compressed. Find out. I am not going the traditional way we do every time. We are focusing on the cell, which is our target to
Yes, sir.
demonstrate.
So in our last webinar, after we finished the webinar, I slept. Even in my dreams, I saw you operating a case.
Uh, Debrider section. Yes, something stuck. See, this is a middle metal enterostomy. I
Yes,
will
sir.
see inside later with a 70-degree. Give me wash. Curved. There go. Yes. This is to flush out if there is any fungus inside. Just edematous mucosa need not to be disturbed for that matter.
Yes.
Edematous mucosa is bound to come back to the normal once you establish the ventilation and drainage. See, quickly I am just enlarging my space
Yes,
to
sir.
go up. See, this is lamina papracia, you can see now.
Yes,
Yes.
yes, yes,
This is, your turbinate here. Can you see?
yes.
I am still with a 0-degree. I am at the axilla. See, this is your frontal process of the maxilla. Opening up the axilla to the fullest. Whenever there is fungus, the fungus itself creates the path for you many a time. Now I will take 70-degree and show you where we are
Yes.
with the navigation. I don't want to catch the mucosa. Wash, section. See that
Yes, sir.
fungus. Now let me have a 70-degree. Can you see the frontal?
Yes, sir.
This is your cell. See behind. See, this is your cell.
Yes.
This cell. This is your frontal sinus. Give me the probe. Navigation. Navigation view, please.
Sir, this is the frontal bullous cell only, na? Which you are showing
See,
now.
this is your frontal.
Frontal, and the behind is yes.
Can you see very clear the frontal?
Yes, sir.
Yes, yes,
Hold on.
yes.
Now. This is your frontal sinus, very clear. It's not moving. Now.
And now moving. Yes.
Yeah, that is your frontal sinus. You can see now.
Yes, sir, we
Yes,
can see.
sir.
In all planes, this
Yes.
is your cell. See that?
Yes.
And
Yes.
that is inside the cell. Not moving.
Wonderful, sir. Yes. And behind the cell will be the cell base.
Yes. So what I will do now, this is my cell. I will not go behind it.
Yes.
It was already dismantled, so I pull the bony part. See this? This is to widen the frontal opening antero-posteriorly. Main view. See how much the frontal is widened
He
now.
can use adenoid blade.
Yeah,
Yes, sir.
adenoid blade can be useful here. You're right. See how much the antero-posterior widening done.
Sir, wonderful. It will open up the supraorbital cell also.
Yes, this one. See
This one.
anteriorly frontal sinus here.
Yes,
Supraorbital
yes.
cell is behind. This is behind. And
Behind.
this is, let me show you the space. There is edematous mucosa where the supraorbital cell is going above the orbit. रुक 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 जा यार. See ball probe. This is where the supraorbital cell is going. See that?
Yes, yes.
See deep
Yes.
inside.
Wonderful
There, this
anatomy
is
of
frontal
the cell
and this is behind the frontal.
behind the frontal.
Yes.
Yes.
Now give me
Wonderful.
marrow cell. Now let me decongest the mucosa. Lamba de patla. Inside the frontal. There is some cobblestone appearance of the mucosa.
Yes, sir.
You need not to do anything for that. Giraffe. I am using this marrow cell to mop the mucosa, to decongest the mucosa. See this. See this
Yes, yes.
marrow cell, just simple marrow cell. And the mucosa is decongested. See the frontal.
Wonderful, sir. Beautiful.
Give me the wash. Similarly, I will decongest the supraorbital. सक्शन कर अंदर जाना नीचे yes now see intermittent irrigation is the best way to improve your picture.
Yes, sir.
Intermittent irrigation all the time. That is frontal. Now the next goal छोटा दे, is to define your supraorbital better, and then rest of the frontal and the ethmoidal and the sphenoid sinus work quickly. No, 120. See a little bit of the, that is the skull base behind. This
Yes,
you
sir.
did.
Yes, yes.
So frontal is a wide opening now. See, this is into the supraorbital cell.
Supraorbital cell. Yes.
Using 70° for laterally. And whenever is the supraorbital cell, I always mention, immediately caudal to that is the,
Anterior ethmoidal artery.
yes, exactly. Give me reverse. And I will show you now the anterior ethmoidal artery. Staying little careful with the reverse blade,
Yes,
adenoid
sir.
blade.
So that's why you were careful while using in this area.
Pardon?
So that's why you didn't use the reverse blade initially because
Yes.
of
See now, this
yes.
polypoidal, and can you see the artery underneath?
Yes,
One,
yes,
yes, sir. Beautifully seen. We can see.
yes,
See the
yes,
artery better now.
yeah.
Wonderful, sir.
This is vessel.
Vessel, yes.
Yes, sir.
Now see the complete clearance of the supraorbital cell.
Yes, sir.
See how wide the frontal opening now is. I hope it is clear.
Very beautiful,
Yes.
sir. Yes.
Beautiful.
Complete widening.
So this is a perfect case to understand the frontal recess anatomy.
Now last 5 minutes for the posethmoid and the sphenoid to move on to the next one. Straight blade. That is your supraorbital cell,
Yes.
completely skeletonized. That is your anterior ethmoidal artery, right there. See now better?
Yes, sir. Very clear.
Completely skeletonizing that. That is the anterior ethmoidal artery. And immediately behind, now see, below, again, coming to the basics, define the roof of maxilla,
Yes.
just parallel to the roof of maxilla. That's a key landmark. Maxillary line. I will enter into the posthmoid. See this?
Yes.
Just at the level of the maxillary line, little widen it. Stay medially, more and more medially. Define the superior turbinate. See that?
Yes, sir. So this is which blade? Red 0, red 40. We are using.
Pardon?
So which blade? Blade.
Straight, straight.
Straight blade.
See, debriding the lower 1/3 of the superior turbinate.
Superior turbinate.
Blocked. And first, before doing a ethmoidectomy, what I am looking for is the front sphenoid sinus ostium. That will be my guide so that I don't inadvertently, accidentally enter into the sphenoid while doing a post-ethmoidectomy.
Yes.
That is an important guide. Before, see, I have a post-ethmoidectomy which I can do any time.
Yes, sir.
But I don't know where I can enter into the sphenoid because this is already as well.
Yes.
So what I will do, from safety point of view, see this? This is your septum.
Septum.
This was your turbinate, superior turbinate.
Superior.
Now along the maxillary line, same again. And along the septum, see this, along the septum.
Yes.
What is this? That's the sphenoid
Sphenoid.
ostium.
Ostium.
Okay?
Yes.
Once I have seen sphenoid, staying anterior to it, you can easily finish off the posterior
Posterior
ethmoidectomy.
ethmoidectomy.
The anterior limit of the posterior ethmoidectomy is the anterior ethmoidal artery.
Yes.
About the skull base, see this. Laterally limit is what?
The lamina.
Lamina. And now, without wasting time, as this posterior ethmoidectomy is finished, we'll widen the sphenoid and that will be done.
Done.
See, until the sphenoid ostium, I can finish off this posterior ethmoidectomy. Not beyond that at this point of time,
Yes, sir.
because I may enter into the sphenoid sinus after that. दिख रहा है क्यों डाल रहा है? See this, see the fungus.
Yes.
Only one tool working, microdebrider. Again, this is my guide, sphenoid ostium.
Yes.
In any given situation, while doing ethmoidectomy, I will not go behind that.
Behind it.
And see, surprisingly, this fungus is behind that. See, this is sphenoid ostium. Until this level, I can do anything. My
And this will
optic
be-
nerve, carotid artery are never going to come anterior to the sphenoid ostium.
Yes, sir.
That is the whole idea. This is the ostium. Now, all these things, see, all these things are behind the level of the ostium.
Ostium.
See this here?
Yes.
Now I will widen the ostium. Widen.
And this is onodi. The above the fungus is going
Yeah,
into
this is onodi. See this.
Yes. Yes.
Some mucosal, Yes. This is the party wall between the sphenoid and onodi.
Yes.
Be careful while running your microdebrider inside the sphenoid. You have to be careful, need to know where exactly you are. And my job is going to be done now. 40 there. Wash and finish. See the maxillary sinus. See the skull base.
Yes.
That is the supraorbital anterethmoid, postethmoidal cavity. See that? That looks like optic nerve here.
Yes.
And give me 40. See, this is full house face.
Full house.
Yeah, full house first and very nicely demonstrated all the major landmarks.
Yeah, I am using 40 here, sir. The reason is the cutting edge is towards me.
Okay.
So I cannot damage anything. रुक जा ना यार. See, as long as your cutting edges are away from the skull base, you are quite safe, So in sphenoid, I was using it towards me. See that? Intersinus septum. Wash. Now the final wash. There was a small lateral recess as well. Nothing. There is nothing. Now what I will do, give मेरे को देना wash. I will remove this marrow cell. Give me wash. नीचे रख. Just to show you the final picture. The frontal above,
Yes, sir.
supraorbital, anterethmoid, posterior sphenoid, maxillary, and this is the sphenoid in the end. That's it.
That's it. Yes. Sir.
That is full house face.
Very nice. Very good.
The next patient is already induced, and that has another anatomy, that is intersinus septal cell, which we need to know from CT scan how it is opening. Otherwise, it can be missed
Yes.
and cause a persistent problem. Wash करके. We'll give it a Dexona wash and then close. बोला दे इधर. बस ये इधर ले आओ. कौन सा लिया? पक्का? हेलो.
Yes, sir.
हेलो.
Yes.
Yes, Satish. We are here
Sir,
with
this
you.
patient has a bilateral pansinusitis with polyps. And let me start from here, most anteriorly. Can you see something very, very prominent?
Septa.
This is your floor.
B.
This is left-sided frontal sinus, right-sided frontal sinus, and all the way equal to the frontal sinus size, you know,
Yes.
even bigger.
Intersinus septal cell.
Intersinus
Bigger.
septal cell. You can open up this sinus, but this cell, if remains, you know, untouched, can lead to problems. So the first thing is, just quickly, we'll finish off like this case quick. I will show one side. And what is there? This cell, how to find out this cell and clear this off. How to find out? This cell surprisingly is opening into both sinus cavities.
Yes.
Majority of the time intersinus cell opens in either of the frontal sinus. Here, see this opening into the right side.
Yes.
And follow this opening, the drainage of this cell. See the drainage of this cell very clear?
Yes.
And see the drainage of this cell over here. Here.
Both sides.
This one.
Yes.
Just
yes.
keep following my cursor.
Mm.
Can you see?
Yes. Sir.
Yes.
So intersinus septal cell, out of all cellularity in the paranasal sinuses, out of agar cell, this cell, that cell, the most anterior of all cells is the intersinus septal cell. Most anterior of all.
Yes.
There are n number of cellular variety you may find in paranasal sinuses. But the most anterior of all of them is intersinus septal cell. So, what we'll do, this side, see the maxillary sinus, nasolacrimal system, this is infraorbital now, this is cribriform, this is a supraorbital recess, see this supraorbital cell.
Yes,
Hello?
sir. Yes. Yes.
Yeah, and anteriorly is the frontal sinus. See, when the frontal sinus ends, the supraorbital starts.
Yes.
And this is the frontal sinus, and this is the cell which is draining into this side of the sinus through this small opening.
Yes.
That you
Small
can
opening.
pick up very well on dynamic imaging. It is opening in the opposite side as well here. And you can make out through the dynamic imaging how the cell is draining. So what we'll do, I will show one side. On this side is the disease. So we'll do the frontal. First of all, this frontal like this. This is the intersinus septal cell. And when we go behind, this is the supraorbital cell. All the three separate openings in that small region. Got my point?
Yes, sir.
In close vicinity, you will find all the three openings. On the right side as well, there is a full maxillary disease, ethmoidal disease, a straightforward frontal sinus. See the frontal sinus drainage, straightforward.
Yes.
No complicacy. And it is normal, being aerated. So on this side, there is nothing much to demonstrate. But this side, we have, three important anatomy. Right from anterior frontal sinus, just medially, intersinus septal cell, and just posteriorly, the supraorbital cell. All these three openings, you have to be careful in identification. You may be mistaken any time. Once you have a huge supraorbital cell, you may be mistaken as a frontal sinus. Or frontal sinus may be mistaken as a supraorbital cell. Sometimes it is not so big. And same with the intersinus septal cell. So I will do on this side, maxillary, and all these three cells, and behind is just postethmoid and as usual sphenoid, nothing great in it. But I hope what I intend to show here
Yes, yes.
is the close proximity of the three openings and three cavities, supraorbital, intersinus septal cell and frontal sinus. So our
Yes.
goal is to see this fine anatomy in this narrow area. Got my point?
Yes, sir.
Rest I am not going to demonstrate. We'll finish it off so that we can take the next one. Camera. Any questions, Udbhav?
No, sir. Sir, Dr. Shravan from Coimbatore is asking, if you have a fungal sinusitis in one sinus, will you do a full house test or will open only that sinus?
Depending upon whether it is a mycetoma, it's an allergic fungal sinusitis, the anatomy of the other sinuses, if there is no anatomical abnormality predisposing problem to the other sinuses, no need to.
Okay.
You may see many a time isolated maxillary or isolated sphenoid sinusitis as a fungal sinusitis.
Yes, yes.
And then if everything is crystal clear with no anatomical abnormality predisposing, there is no point in doing. If there is some anatomical abnormality predisposing sinusitis in the other sinuses, like if you have a, ethmoidal disease, you have a frontal cellularity, better to finish off rather than
Yes.
waiting for the disease, which may occur later on, not because of fungus, otherwise
अरे
also.
आरती एक ही बैटरी कनेक्ट कर दो पावर बैंक से
Pardon? Just was getting ready for the next case. Are you getting the picture?
Yes, sir, we are getting it.
This is the primary picture. What is
विदाउट
there?
डीकल
See the disease. See the massive DNS.
Yes.
So it is always better to correct the DNS also for the access. Minimal correction for the access,
Yes, sir.
That is important for your intraoperative course as well as post-operative irrigation point of view.
Yes.
See my topical preparation. No infiltration even for the septum. See the opposite side.
Yes.
This patient has a classical complaint of headache. See the purulent discharge.
Yes.
So this is topical preparation along with the pre-operative preparation, anesthesia part. Everything is important for good
Yes,
surgical
sir.
field.
Yes,
Satish,
sir.
did you give steroid pre-operatively in all these cases?
By and large, sir, yes, to reduce the inflammation because
Even
of
in
the
this case?
ongoing inflammation, there is a lot of edema and all these things which contributes to more bleeding intraoperatively. Who did it? Who?
Even in this case, you have given.
Yes, yes. This case only for 3 days we have given.
Okay.
See, I am decongesting the mucosa. Simple application. If you try to pack tightly, it is counterproductive, you know. So never ever pack tightly. See, without the septal correction, we won't get good access. Can you see how compromised is the airway? And more importantly, the access. So I will do a sort of septoplasty here, the limited one. So I will make my incision here anteriorly. I can use my, Colorado needle here. On. Suction. Hello.
Yes, sir.
I am using my Colorado needle here for the initial incision marking, you know.
Yes.
उठा ना इसको ऊपर वाले. Just to avoid unnecessarily bleeding in the beginning. See the plane?
Yes.
And this is without infiltration.
Yes.
You know, Colorado. Now I am finding the bony cartilaginous junction. Can you see?
Yes.
Yes.
See this bony deviation from above, giving me high deviation.
Yes.
That is my target. Well, to the opposite side, you can see. See the opposite side?
Yes. Sir.
Yes, sir. Yes.
And I will punch out some bone to get rid of this high deviation. See, my target is this high deviation.
Yes, sir.
See now the excess?
Yes. Wonderful, sir.
Some more.
So we are having spur also in this case, right?
Yeah, we'll correct that as well.
Yes.
But my goal of this Removal of the high deviation is for the excess.
Access.
Knife. See, once this high deviation is corrected, you'll find a significant difference in the axis.
Yes, sir.
This is the problem.
Yes.
And this is quite far off from the, dorsum.
Yes.
So don't bother. See, I'm not pulling. You have to punch out.
Yes.
You're not supposed to pull to give a dorsal deformity. A lot of people wrote us to show the endoscopic septoplasty.
Yes, sir. Yes, sir. That's why I was asking you to show the spur correction also.
No, yeah, the septoplasty at different indications. Now see my axis.
Yes, sir.
Now I can do my work above nicely without any issues. Now the
Yes.
spur what you are talking about,
Yes, yes.
let me show you that also in a minute.
Sir, I know you can do this case without the spur correction, but for the juniors, it will be a nice.
But it is better to correct in this case as well.
Yes.
Quite significant it is. See this?
Yes.
Otherwise, see my high deviation has gone.
Gone, gone.
See how it has pushed the turbinate, made it floppy.
Floppy.
It should be like this.
Yes.
Give me a Merocell. I will do a micro fracturing of this turbinate to give a wide access in the middle meter. See this?
Yes.
How to do micro fracturing? Give me. See this? Suction kar. Let me show you. Yes, suction. See this turbinate?
Yes.
I can feel the crack,
Rattling sound.
and then push your Merocell into it for a minute.
Yes.
This will bring the turbinate close to the septum and open up the middle meter like this.
Yes.
Very
See the
nice.
turbinate?
Very nice. Small.
Inferiorly gentle
Very
micro
nice.
fracturing. Though
But
this
usually it
looks
comes
like.
back.
Pardon, boss?
Usually it comes back in due course of time. In,
Yeah,
late-
it may. So if you find it still floppy, we'll do a wedge resection. If you find floppy, you can suture it. There are many ways. Now,
Vulgarized.
wash. Coming to the spur, wash. Yes. Yeah, wash. Niche kar. See, you have to stay in the subperiosteal plane.
Yes.
Now, give me knife. See this deviated portion below. I will cut this strip all the way. There are many ways to do this. Here I am cutting this strip.
Yes.
There is way to preserve this strip as well. No point. Stop later. चालू कर See this strip of cartilage?
Yes, sir.
Now, we'll go to opposite side. Because of the deviation on the same side
Yes.
and the sharp spur, I may come across a little bit of the, tear, but the opposite side should remain intact.
Yes. Wonderful, sir.
See the tear on the same side?
Yes. Yes.
What I will do now,
Aaron?
अरे, देखना देखना. See this, a separation of the periosteum. Separation of the periosteum of the opposite side to keep it intact.
Yes.
See now, separated intact. See, completely separated.
Yes. Yes.
Till posterior part where the deviation is. See this?
Yes, sir.
This is deviated portion here. See this?
Yes.
And the opposite side completely separated.
Yes.
Prior to avoid any possibility of a perforation, till floor. See the opposite side.
Yes,
The
sir.
one side flap remains intact, nothing is going to happen.
Yes.
Because this side is expected. See this?
Yes.
Such a sharp angulation.
Very sharp. Yes, sir.
My God. Anyway, give me. Every septoplasty is different.
Yes.
Oh. Look, the tear on the opposite side. That is not just opposite. It should not be completely opposite this side, otherwise may result in perforation. See this?
Yes, sir.
Thin bone leading to spur. Action करना. See this thin bone leading to spur.
Yes, sir.
On this side. You have to be careful not to give a perforation. See this sharp spur now
Yes. Yes.
behind. See what a sharp spur there.
Yes.
That is the part of the cartilage. And finally, this is the spur that we have to get rid of. See this?
Yes, sir.
Helicopter.
Yes.
Yes, this
Yes.
is the
So
final piece.
see, the tear should not come opposite to each other to give perforation. Nothing will happen now.
Yes, sir.
There is a tear on the opposite side, but it's not opposite to the
Yes, sir. Yes.
Flat.
tear of this side. So it will not. Once you put the marrow cell, it will stick.
Stick.
And we can remove this bone as well. The anterior most bone. See this?
Yes, yes,
Give
yes.
me a chisel and hammer. क्यों कर ये बड़ी है यार तो दूर कर हम्म हम्म see this that's it
Yes.
that's the bony spur
Yes. Yes, yes.
in the floor and now we'll not do anything just leave it like that
Yes, sir. Now full access.
give me a marrow cell in the floor this is to give a good airway as well
Yes, sir.
see now once the flap do not come opposite to each other this tear will pull them and stitch together in the end we'll pull them and stitch together there will not be any perforation you can see this I will pull them and stitch together like this okay okay can you hear
Yes,
me
yes.
yes now coming to the core issue wash I kept this marrow cell so that my flaps will not come my way again and again see this marrow cell in the floor this marrow cell will always protect this one and our area of interest is above okay so the first step this is your uncinate see this uncinate mobile structure confirm use your reverse biting engage turn it down turn it down turn it down and this is what you see the maxilla the secretions coming out see the I told you this patient came with headache just widening the middle metal and trust me they're full of infection see this is pure non-polypoidal sinusitis
Bacterial sinusitis.
and this is very rewarding as compared to the polypoidal one वॉश देना मेरे को देख काउंट में just to rinse the maxillary sinus oh यार कर दिया that one पतला ले यार section always a thin one curved So that is the middle metal antrostomy. We can come to that later with when we come with 70 degree. This is the upper part of the uncinate. Visible?
Yes, sir.
This is the upper part of the uncinate. Fracture it out anteriorly. Simple. See? It will come. And as I debride the upper part of the uncinate, the anatomy I want to see next is the medial wall of our orbit or the lateral wall of our corridor. See, that is the medial wall of the orbit. See the uncinate? Behind is your bulla. Completely open it to the axilla. This is your Agarneji cell. Widen the axilla thoroughly at this point of time. And then switch to 70 degree. Very interesting anatomy in this case. As we go to the frontal, recently, Professor Richard Harvey described the technique, Caroline's window to the frontal sinus. See, this is done with a 0 degree so far. Widen the exposure here. Now, peg there. I'll put a marrow cell and come with 70 degree. See this. Pull it. See that? Now remember what we saw in CT scan. Frontal sinus, supraorbital cell and the intersinus septal cell. All three together in this patient. Now 70 degree. Hello?
Yes.
Yeah. So this is now with a 70 degree.
Yes.
This is your bulla. Keeping the bulla intact. See now, what I need to take into consideration. What I need to take into consideration at this point of time, this is my lateral limit, this is my medial limit,
Yes.
and this
Is our area of
beak is going to be my anterior limit, and where the beak ends, see this, that is going to be the frontal where I can see the pus pouring out. Let me open it first. See that? So simple.
Yes.
I have my lateral limit in view. Here it is. I have my medial limit terminate in view. And this is my beak. Where the beak ends we saw in the CT scan. Every time it has to be frontal sinus. Okay?
Yes.
So this is number one, my frontal sinus. See that?
Yes. Clear.
Now, this is opening number one. Okay? Can you see the opening number 1?
Yes, yes.
No. Now, coming medially and anteriorly. See this?
Yes.
Medially and anteriorly. Can you see the opening number 2? Can you see
Intraseptal
the
frontal
opening number
sinus cell
2
opening.
medially?
Yes. Yes, yes.
What is that?
Intraseptal
Intersinus septal cell.
sinus septal.
I could see it is opening here into it. Now still one more opening which is need to be seen so that the frontal sinus drainage pathway doesn't compromise. This is 2. Okay. Now we all know the supraorbital cell is always a posterior anatomy. Okay.
Yes.
This is frontal sinus. See now. If I go posterior to the frontal sinus, let me first clean these 2 openings for you. These 2 openings, very clear?
Yes, 2 opening clear.
Now the third one. I have to widen. Calm down, yaar. Let me clean them. Irrigate. Marrow cell. Reverse. Give me reverse now. See, had we not done the septoplasty, we would not have this access to work with 70 degree in the presence of the high deviation like this. See the access we got.
Yes.
See, as we corrected the high deviation, septum got straight and above. Can you see?
Yes, yes. Wonderful.
This would not have been possible without that septal correction. High deviation. So once you have to work in the frontal, see the 2 openings. Now, coming with the reverse one. Back. Because we know the supraorbital cell is a posterior opening, I am coming posteriorly. बंद हो गया. वो 40 दे दे. Forty. See this third opening now behind.
Yes.
Can you see that behind going
Yes,
up and
yes.
above?
Yes, yes. Very clear.
That is supraorbital. Now how can, see these 2 openings narrow the frontal outflow. One from medially, one from laterally. And the treatment is remove the party wall. I have already removed the party wall partly between the intersinus septal cell and the frontal. Now I am removing the party wall. I am removing the party wall between the frontal and the supraorbital. See that, the bone I have removed. See wide.
Very wide.
See easily all the 3 openings. There should not be any confusion.
Could you please define again the Carolus window of Dr. William Harvey?
Okay. I should show
This
one
is
of the
Caroline's
case.
window. Before
your
your
I will show in one of the case to simplify it. But by
Yeah,
and large,
put
what is that? Come with a 0 degree. What he says.
People want to see it actually.
Come with the 0 degree. Remove this, cauterize this mucosa. Cauterize this mucosa of a triangular zone above the axilla, like this.
Yeah.
Remove this mucosa and with 0 degree drill away this bone.
Yes.
Drill away this bone, partly the beak to enter into the frontal directly. He wants to drill this bone, this, where my suction is.
Yes.
Till here. So you can do the frontal sinus work with a 30 degree or so.
Yes.
See now all the 3 openings. I hope it is clear.
Yeah, beautiful. Beautiful.
Now where is the anterethmoidal artery for that matter? There are 2 landmarks. I have mentioned couple of times. Number 1, immediately caudal to the supraorbital. Okay? And second landmark is behind the bulla. Okay? With the 70 degree, let me go behind the bulla and fracture it out anteriorly. See this? And this should open the skull base above where the anterethmoidal artery runs. See, every sinus case, if some different cell, we must be able to diagnose it and we must be able to follow it. That is the whole game behind showing the variations. Now see, I am opening the skull base. See the purulent discharge. This is anteriorly, see the supraorbital cell?
Yes.
And that is the anterethmoidal artery behind that.
What if you would have opened up bulla before, ethmoid before going into the supraorbital cell?
Bulla?
If you would have opened bulla before going to
Supraorbital cell, supraorbital cell, once you know, is an anatomy immediately behind the frontal sinus, for that matter, number 1.
Yeah.
And it narrows the frontal sinus from behind. So it's always be respected in relation to the frontal sinus. See the anterethmoidal artery.
Yeah, very clear.
Once I remove the bulla, see artery, how it was protected by bulla. This technique was initially popularized by none other than Dr. Sethi.
Yeah.
Intact bulla technique. See this? Now give me the reverse and skeletonize the vessel like we did in the last case. See the vessel there?
Yes.
What you can do now is widen your supraorbital axis. See this? With the reverse. See how important is 70 degree.
Yes.
In the first case, we did the orbital transposition with the help of 70 degree. Now you can see the anterethmoidal artery in the immediate caudal relationship to the supraorbital cell. That is the artery, okay? That is the artery there. This is supraorbital. Give me 120. See all the 3 openings. That was the basic goal behind demonstration of this case. The intersinus septal cell, the frontal sinus and the supraorbital. No one should get confused with this concept. These are cells which can, complicate your frontal sinus surgery. One must be able to pick up them first on the preoperative imaging and then follow them intraoperatively. Okay? The rest of the work is same like we have shown a couple of times. On this side, what is left behind? This is maxillary. We'll flush it further. What is left behind is the post-ethmoid and sphenoid like you saw in the previous case just now. Okay? So this
Yes.
was the thing to be demonstrated. That is the main thing. Okay? The rest I am not going to demonstrate.
Yes, sir.
Will be finished by your colleague. And the rest of the ethmoid and the sphenoid work and some little bit work on the opposite side will be shown, will be done. So in this case, the relevant thing was this complex anatomy. I hope this was well taken.
Well
Yes,
taken.
yes.
Absolutely.
Believe me, it's not difficult. It is, radiological correlation. See again to the CT scan. See again to the CT scan. The most
Yes,
anterior
this
one, the frontal sinus and the supraorbital cell. As I go behind, see just anteriorly here, it gives a path. Can you see?
Yes, yes.
So I open the frontal sinus behind the, beak. This is the beak. See this?
Yeah, yeah.
As the beak ended, this was the frontal sinus. Clear? And
yes.
here medially, where the frontal recess started, just medially was the access to the supraorbital, the intersinus septal cell. I hope it is clear.
Yes,
Yeah,
clear.
And as you go behind, this behind is the supraorbital cell, and we remove the party wall. We remove the party wall with the frontal sinus to widen it. See this party wall. Okay?
yeah, yeah. Beautiful. Good.
The last case of the day, we had to include him because he has visual symptoms with irritation and blurring of the vision in the left eye started. And when we got the scan done, see what is there in the sphenoid. Can you see this heterogeneous
yes.
density?
Yes, yes, yes.
Not yet opened. Opening.
Okay, okay. Then you
This
can
part
see
of
that.
this part of the optic nerve is exposed.
Yeah, dissent. Yeah.
I will show an MRI. Very interesting. See on CT scan. Can you see this fungus?
Yeah, yeah. Very clearly.
And see the optic nerve which is coming and here in contact with the fungus. Can you see very clear?
Yeah, very clear, very clear.
Here this part of the nerve is dehiscent where it has come in contact with the fungus, which has given him
Yes.
symptoms. Okay?
Yes, beautiful. Good case.
And now the coronal scan. Now see the here this part of the sphenoid wall is dehiscent. And this part of the fungus, this part of the fungus in onodi, see this is the optic nerve. See this is where my cursor is.
Yes.
Yeah, yeah.
Here is in contact with the fungus. See this here.
Clear.
Clear?
Yes, 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 yes.
Now look at the MRI. I'll show you some fine section in the contrast. Yes. Can you see the optic now coming out?
Yes.
Yeah, yeah. Very clear.
And see the fungus there. This in the onodi cell. See this. See how
Yes,
this
yes.
fungus is in relation to the optic nerve.
And now
Almost
look
in
at the
touch. Yeah, yeah.
Very clear?
Yes, yes, beautiful.
It is the cause behind problem. And you can see in 3D also. There are certain sequences which can be reconstructed 3D, not all. And this is one of them. And I will pick up on axial what we saw just now. Just now here. See this? if I bring here or I bring right on the optic now, see in all planes. See here, this is optic now. This is optic now coming in the orbit. See carefully, this is optic now.
Yes, yes.
And see this, how it is going. Going. See this.
Yes, yes.
So, this part of the optic now, this part is in relation to the fungus here. This is onodi cell.
Yeah. Yes, yes.
In the sphenoid, the upper cell is onodi, the lower one is the sphenoid. And this is where the optic now is in contact with the, this is the optic now, and this is the fungal material giving the inflammation in the nerve. And this is the straightforward situation. Again, that's the final case of the day. And after this, we'll meet on 6th of September with a course on ear surgery. External to the inner ear is the theme, from morning 10 o'clock. So let us see the other anatomy in this particular patient. See from anterior, frontals are clear. Maxillary, a little bit of the, opacity, hardly anything. Huge septal deviation, see the same.
Same.
See the spur. See, so far there is no disease now. This is the level of the posterior ethmoid. And see the fungus with erosion of the posterior ethmoidal skull base. And here is the onodi. See this posterior ethmoidal cell. See this posterior ethmoidal cell going behind and above the frontal sinus. See where my cursor is. See this. This cell is onodi. Can you see?
Yes.
This is optic now. This is onodi, and the sphenoid sinus is below. This sphenoid sinus is below, and onodi is above. And if I come anteriorly, see the fungus in the onodi. So onodi is the basic problem in this case overall. There is hardly anything else.
Yes.
So we'll do the same side, the middle meatal enterostomy. Opposite side is normal. Opposite side is normal all the way. Except at the sphenoid level, I may have to remove this intersinus septum to clear it, or anything. I'll just show the onodi to, call it a day. See, this is my optic now, and here is in the contact with the onodi. So let's go ahead if things are ready. 2 minutes. Any question, Udbhav, for the day? Anything?
Sir, I will ask. Yes, sir.
See if there is
Sir,
any
Dr.
question from the audience.
Sir, Dr. Palaniappam is asking, what are the incidences of intersinus cell you encounter?
It's quite common, not uncommon. But this was a big one, simulating the frontal sinus itself. That was an interesting situation. That's why we kept it.
Yes, sir.
Sometimes, majority of the time, they are small.
Yes. Sir, how often do you send pus CS swab in case of sinusitis?
How often?
Sir, pus CS. Do you send swab for pus CS if you are finding any secretion coming from meatus?
In sinusitis, once you establish the drainage and start irrigation with the patency established, aeration established, the disease part you removed with flushed, everything flushed out.
Yes.
No point in, dealing with the infection. It has to come down with any broad spectrum. Obviously, you have to give post-operatively some broad spectrum antibiotic.
Yes.
but this is hardly a concern.
Sir, Dr. Vinod is asking, can you explain Caroline window?
Caroline window, I told you, in frontal sinus, he removes the part of the floor of the frontal sinus by
Yes.
removing the axillary bone.
Yes,
The
yes.
other name of this, Caroline window, you can call it as axillectomy.
Okay, okay.
Like I drew in the last case in the end. Remove the mucosa at the level of the axilla, that triangular one, and
Yes,
drill
sir.
away the bone to reach into the frontal directly with 0 degree.
Yes.
So that is something like axillectomy, you can say.
Axillectomy.
Yes,
Yes, sir.
the synonym is axillectomy. I will
Axillectomy.
show in the coming webinar sometime
Yes, sir.
for a frontal sinus disease. What is Caroline's window? For the sake of discussion.
Sir, Dr. Fezali from Peshawar is requesting to show any endoscopic DCR and septal perforation repair in future webinars.
Yes, yes, definitely. Mero sir. Hello,
Yes, sir.
are you getting the picture?
Yes, sir, we are getting it.
This is topical preparation. We have seen there is a spur on this side like previous case.
Yes.
So we have seen that basically how to handle that. So I'm not going to show here on this side. Though we'll do something in the end, the demonstration.
Sir, is this a paradoxical middle turbinate?
Yeah, because of this septal deviation.
Septal deviation. Yes.
See this turbinate has been pushed.
Satish,
Yes, yes.
Satish,
Yes, boss.
just ask someone to open the video so you can show them, show all of them how to douche the nasal cavity in post-op cavity. So just
Okay.
people want to see it. So it
Okay.
must be in
After
your
this
video.
surgery. After this
Yes,
surgery.
yes, yes.
See, the space is adequate for us for carrying out our work. And I will not go towards the frontal sinus. My target is one and only onod cell. The sphenoid. We can do a middle meatal enterostomy with some, secretions. Debrider. How is the picture?
Very good.
Very good.
This is uncinate.
Yes,
Yeah.
sir.
Another important finding I forgot to tell you about this patient. I will show you. See this polyp in the maxillary sinus. This is the uncinate. Sometimes I don't use any other instrument than debrider. There are many ways to do the same thing. Just to expedite the process.
Yes, sir.
So we have already done the middle meatal enterostomy. That's the part of the uncinate. Part of the bulla, which is again compressed. This patient has a typical finding I will show in the clival dura after this surgery that we notice. And that's how he complained of headache also. Those other
Clival dura.
clival dural meningitis.
Okay.
I will show at the end. See, immediately after that, once you remove the uncinate, focus on the orbital wall. That is the biggest
Yes.
landmark. Once you remove the upper part of the uncinate and see the next landmark, this is your part of the bulla.
Bulla.
See how it is compressed. Scissors. I am not going above to give any problem to the frontal. No, straight. See the maxillary sinus, the roof of the maxilla landmark,
Yes, sir.
the orbit as a landmark,
Yes.
and in no time we will be right on the target. No time. See, that is the recess for the frontal,
Yes,
above
sir.
and medially. See that?
Yes, yes.
Which I don't want to disturb the mucosa. See that up.
Yes, sir.
I have taken, and this is what I have reached to the sphenoid. See the fungus. Can you see?
Yes, sir.
Yes, yes.
Okay, in this particular patient, I am intentionally removing the lower part of the turbinate because I have to ensure the sphenoid irrigation in the future, because he has already presented with such a massive symptom. See this?
Yes, yes.
This lower part of the turbinate, that's it. Nothing much. The upper part remains same. And I'll have a amazing exposure now, Wash, to show you something about the onodi. Debrider. Give me a pack for a while, just to remind you of the important landmarks. Just to show you. Septo करना है इसके बाद में. See, this is my nasal septum.
Yes, sir.
This is my level of the roof of the maxilla.
Yes.
And here, these are the polyps. This is part of the superior turbinate which I intend to remove. See this anteriorly?
Yes,
Yes.
sir.
This one. Yes. See, this is sphenoid.
Yes, sir.
Now, once we have seen the sphenoid sinus, I will carry out the post-ethmoidectomy. Can you see the anode cell opening?
Yes,
Yes,
sir.
yes.
Yes, yes, yes.
This is the post-ethmoidal cell above. See the fungus, which is the cause of the problem. Just to orient you with the anterethmoidal skull base. See the anterethmoidal skull base anteriorly.
Yes, sir.
Yes, yes.
This is the problem. This fungus is the issue. So I'm not removing it right now, just to orient you all the time. See the sphenoid sinus below,
Yes, sir.
and above is what? Onodi.
Onodi.
Yes, sir.
See the relationship.
Yes, sir.
That's
Beautifully
why I
seen.
didn't remove the fungus, to show you the relationship. See, it's a game of 3D anatomy. Now see the coina below.
Yes.
See the maxillary sinus here,
Yes.
and see the sphenoid there. And see the culprit above here. I hope you are oriented.
Yes, sir. Yes.
Yes, yes.
Very, very much.
And see this cell. See some disease behind, below in the sphenoid. Now I am removing this onodi,
Onodi.
this fungus. Yes, this one. And you know, this is my optic now.
Yes.
See the optic now?
Yes, yes. Yes, yes.
Sir, the cell is attaching right onto the optic nerve.
Yeah. So we correlated this very well on radiology,
Yes.
that this guy is onodi, and that is directly in contact with the optic nerve, giving rise to inflammation.
Hello. Yes.
See this? I'm
Yes,
not
sir.
doing
Ah,
anything to the optic nerve there.
मैंने नहीं.
But the optic
किसमें?
nerve is absolutely decompressed.
Yes.
Once you remove the fungus, the entire, see the optic nerve very clear.
Very clear, sir.
Anteriorly, the anterethmoidal skull base, we didn't disturb. See this, absolutely normal. Now give me 40. Now I will just do a decongestion over there. See, irrigation is the main tool throughout the surgery for us. छोटा मेरो सेल, छोटा और छोटा. See, this is the marrow cell which I want to keep here to decongest. See now the optic now.
Yes, sir. Yes.
Curved. And now finally, little bit of the, this mucosal edema and fungus. See here posteriorly, I am using the red 40 where the cutting edges is towards me
Yes.
because this clival dura is decent there at some places. See this? See this clival dura behind? Oh, see this?
Yes.
I don't want to disturb that, but this is simply because of this.
But sir, I think for beginners, they should avoid using any instrument in the sphenoid sinus.
Yes, never.
Yes.
That is clival recess, and I will show why I was saying clival dura is decent. This because this patient has a funny finding. Now see this is the required part for this patient which we have done. The important part which we wanted to demonstrate how a onod cell can lead to problem,
Yes.
Yes, that's it. Okay.
Yes, sir.
तो इसको पैक वो करना वॉश कर सेप्टो करनी है so they'll finish up the septoplasty and then I will show you coming back to the radiology.
Yeah, now the correlation with clival coming back.
Yeah, coming back to the radiology now. Disconnect हो गया. Yeah. Can you see the screen?
Yes, sir.
Yes.
This is a contrast picture. This is the sphenoid sinus with the fungus which is not enhancing much. And that was the optic nerve which was compressed by the fungus here. Can you see this?
Yes,
Yeah,
sir.
that's one.
Yes.
Now see the funny finding. This is the sphenoid, this is the clival recess. And see behind the clival dura which is enhancing. That is classical of
Okay.
meningitis. Can you see this?
Okay.
Yes, sir. Yes.
So we
Yes.
notice this patient has a headache as well, and this could be the reason. Now we are in fix. Since it is meningitis, we have to give antibiotics. Since it is non-invasive, there is no point in giving antifungals. But
Yes,
it is
sir.
rare to see in AFRS patient developing meningitis. So here we are in fix whether to give itraconazole along with this or not. So we may give a short course of itraconazole
To be on safer side.
to stay on safer side. Exactly. Now see on the sagittal as well. See on sagittal, this clival dura.
Yes.
And see this sphenoid component, this is the clivus bone,
Yes, sir.
which is resorbed completely, and this sphenoid bone, when I was removing from the sphenoid with a 40, I showed
Yeah.
you till the clival dura, the dura is decent.
Yes.
Yes, sir.
Everything is important. If you are not careful about it, if you don't know that the clival dura is decent, we can lead to a disaster.
Yes, sir. Sir, Dr. Palaniappam is asking, can you show the relationship of ophthalmic artery with the nerve, optic nerve?
Ophthalmic artery, if you remember, I have shown earlier, that can be shown on angiogram.
Yes.
If you want, I can show you, but that is on CT angiogram.
CT angiogram, yes.
Ophthalmic artery can be seen on MR angiogram also. On a time of flight sequence on MR angiogram, you can see the ophthalmic artery. I can show you on both.
Yes.
Just a minute. Ophthalmic artery, let me show you. Okay. I will show you on this CT angiogram.
Yes, yes.
Convey my regards to Dr. Palaniappan.
Sir, he has been
Always
following
been
all,
associated and come up
from
with
beginning,
very good
and sir,
questions and suggestions.
from beginning till the end in every webinar.
Yeah. See this. Now, what is to be known about the ophthalmic artery? Where it is given off and how it enters the optic canal along with the optic nerve, and in the orbit how it crosses the optic nerve across from lateral to medial to reach the medial side and divide into anterior and posterior ethmoidal arteries. Let us
Yes.
see.
Yes.
Let us see. See, this is the cavernous carotid. Can you see?
Yes. Yes. Yes.
As you come here above, this is the level where the ophthalmic artery is given off.
Yes.
See, this is ophthalmic artery which is given off.
Yes.
Can you see this ophthalmic artery? And
Yes,
the
yes.
supraclinoid segment here, the first subarachnoid branch of the carotid, internal carotid, is ophthalmic artery.
Yes.
Now follow this artery going in the orbit. Can you see? Can you see
Yes.
this artery going into the orbit?
Yes. 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 Yes.
See how it is going laterally and then crossing the optic nerve. I will show you. Let me show you the optic nerve first. This is optic nerve.
Yes.
And see how this artery crossing the optic nerve. See this. From lateral to medial. Can you see?
Wonderful, sir.
Now, how it gives off branches. See this. If you follow the course, here it gives the anterior ethmoidal artery.
Okay.
Very tiny branch. See this anterior ethmoidal artery?
Yes, sir.
If you want to see better, I will show on coronal. Better.
Yes.
See this? The carotid. Let me start the carotid course for everyone. This is the cervical part.
Yes, sir.
Cervical
Yes.
part enters
Yes.
the petrous bone, vertical
Yes.
petrous,
Yes.
anterior to the
Yes.
cochlea turns horizontal. This is horizontal. Then at the foramen lacerum it becomes cavernous.
Wonderful, sir. Yes.
Cavernous, and here ultimately divides into anterior and middle cerebral. Okay?
Yes. Yes.
Now before that here, see that it has given rise to this ophthalmic artery.
Yes.
Now follow this ophthalmic artery. Follow this ophthalmic artery retrograde in the orbit. Can you see I am coming in the orbit?
Yes.
Yes.
Very clear this vessel?
Yes.
Yes. Yes.
This is the ophthalmic artery.
Yes.
Now, see this. Now this artery, see this at this level. It is giving a huge lateral branch. Can you see this?
Yes. Yes.
This is lacrimal artery. The largest of the branch of ophthalmic artery is the lacrimal artery.
Fine.
And sometimes it is life-saving, believe me. Not life-saving, but eye-saving. I have come across in my life two situations wherein in the huge JNAs, we had to coil the, internal carotid. And the coiling was done from the petrous to the supraclinoid in close proximity to the ophthalmic. And my intervention radiologist was very concerned that it may, affect the ophthalmic. And the patient may develop blindness if it closes the ophthalmic. I asked him to get the external carotid angiogram done. And then I found this lacrimal branch. This lacrimal branch has a huge, collateral with the recurrent meningeal artery.
Oh, so
And a
that
branch,
was
collateral circulation coming from the middle meningeal artery. In that case, in spite of, sacrificing the ophthalmic with a coil, the patient survived the vision. I told you this is, on angiogram you can pick up. So this is ophthalmic artery.
Yes.
This is lacrimal artery going. Forget about that. Follow the ophthalmic artery now. Follow the ophthalmic artery. Follow the ophthalmic artery. Now see where it is coming.
Yes.
Follow anteriorly. Follow this. Follow this. See now where it is coming. Yeah. See this branch?
Yes, yes.
Our angiogram, time of flight sequence, you can follow the ophthalmic artery. Not only that, its branches as well. And this is important when you contemplate procedure in that vicinity. You should sit yourself with the angiogram and see, because the implications are very high. If you are not aware of this, and unfortunately patient develop blindness by your ignorance, this is something, it is very painful. Not only to the patient but the surgeon as well, because you can do your best. Anybody, everybody, I would say, any human being can ignore something.
Yes,
So
sir.
we have to be extra careful in regions which are vital. And orbit is vital, vision is vital, carotid is vital. These areas should be given extra importance. And CT angiograms, I sit at least half an hour with every CT angiogram to see cross communication, collaterals, ophthalmic, carotid, branches, everything, all implications. You should be prepared with every possible, unfortunate consequences.
Yes, sir.
And majority of them are preventable. That is the best part. Majority of them are preventable. The only thing you required is how conscious you are. Because the onus is on us for giving the result to the patient, not the radiologist.
Yes, sir.
What the radiologist is going to tell you in this situation, he cannot. And if you ask, somebody asked me about giving me the format he had given to the radiologist. He torn the format in 3 days. 300 points he cannot write. He cannot invest 3 hours to, report a MRI or a CT angiogram. He said, better I will not do any time for you in future, but I cannot do this thing. This is practical. If a radiologist spends 3 hours for reporting, he cannot do 4 or 5 scans a day, he cannot survive. This is practical. The thing is, you have to learn this and do yourself, and you can, save lot of things.
Yes,
This is
sir.
my submission. This is what we are following, and this is what we are propagating. And this is not difficult, I tell you. You have to be committed to it to get the good radiological investigation done, to be in touch with radiologists. In any difficulty, you can learn fine tuning with them. If you make a team, they will never, hesitate in telling you all fine details. And over the period of time, you will learn yourself and, than 1 and 111 like you and radiologist. Sometimes I learned a lot from my radiologist. Sometimes I have corrected him from his diagnosis. Believe me, it's not exaggerating, but this is a fact because this is 1 and 111. Many a time in our practice, I've been saved by my junior colleagues. Boss, I see this vessel is there. Can you review? And I was wrong. So this is something you have to learn from each other.
Yes, sir.
Any junior colleague of you is saying something, never ignore. Because they spend a lot of time into it and then say something. And this is something important. Thank you, Dr. Paniyappan. And any more questions, Udbhav?
No, sir, we have covered all the questions. People are excited about your 6th September event. They are asking for the link, details, how to be part of it.
See, we will send the link, and it's our dream event. Thanks to Sun Pharma, thanks to Chori Boss, and thanks to our dear friends Dr. Ashish Bhumkar and Ashim Desai who have consented. And I'm trying my best to go to Agra and drag Dr. Pachori to Jaipur to do a case for us to demonstrate. Believe
Awesome,
me.
sir. So this will be
This will be very nice.
He has never refused. He has practically agreed. But any problem in case, I will go to Agra and drag him, pull him.
nice, sir.
He has always been
but
so
thank you.
kind. He has always been so kind to me, and he does a lot of cochlear implant surgeries.
Yes.
He does by equally good, with equal efficiency by posterior tympanotomy and varia. That's a good point of discussion as well, pros and cons. Last week he did 11 implants. Unbelievable.
Oh,
Where is Pachori boss? Hello boss.
he's
But
not here, sir.
Satish, in UP we have started doing implants and we are doing plenty. All of us are doing plenty of implants because
Yes, I am here. No
I
problem.
government has
I
also
know,
taken
sir.
up.
Pachori boss always tells me about you, the kind of otology work you are doing. You list more than 10 cases, this and that, and your experience is almost 40 years.
Yeah, but you are
We are
far
far off
excellent.
from
I'll tell
that.
you. Yeah.
Experience sometimes
Every
saves you
time
from
I
problem.
see your surgery, every surgery is a showstopper. I have never ever seen come across any other surgeon so energetic, so dynamic, and so full of knowledge. You have always given us so much knowledge that every day we spend with you is highly satisfying. I feel that you made my day today and
Sir,
always.
we are
And
grateful to
always,
you for
whenever I have
sparing
seen
your
your
valuable
surgery,
time, sir.
and you make me spellbound with each and every and the way you explain it three-dimensionally and correlate surgical anatomy and radiology and integrate with surgery, it's exceptional. I have traveled world, but
I'm always in the learning phase, sir. We have to learn
very
from
few
you.
places you will find, and I have yet to find a teacher like you. To be honest, no exaggerations.
Sir, thank
And
you, sir.
I have seen many centers and many big doctors, many great surgeons, and work with them, but none like you. I have to say, you are proud of India.
You know
Indian
what I told
surgeons.
Pachori boss? Your son is most fortunate who is learning from you out of
Yeah,
your
he will learn
experience.
from you one day. Don't worry, he'll come to you, and
Sir.
hopefully you will take him under your arms and make him a better surgeon than he can be.
Thank you, sir.
Thank you.
Again, I have a big, gratitude to Sun Pharma.
Yeah.
Thank you, sir.
Believe me, they
Yes.
never raised any single problem. I'm talking very frank. They have been so supportive.
Their
Sun Pharma
contribution
has
to
been
ENT
always
specialty will be remembered.
unconditional. We want to this, he said, go ahead. We want this kind of telecast, go ahead. Never a no. Sometimes we took liberty to do anything without talking to them, and they are so comfortable. Thank you, sir.
Yeah, and their contribution will be remembered by all
Yeah.
of
Sir,
the
All
thank
ever.
you,
I
ENTs.
am
sir.
always grateful.
I hope they will respond.
Thank you. And I have already mentioned on
On
6th of
behalf of
September, a day before I am going to Agra to bring Pachori boss to Jaipur
That will be
for our
wonderful.
dream
Clap for
event.
him.
I'm with
We
you. I'm
clap
with you.
for him in
Already
advance.
requested him to come and show something, and he practically has agreed. What he said, we don't know what the situation is going to be on 6th, but I am very very hopeful that he is going to be with us. So on 6th will be our full team, dream team. I always call dream team because I learnt a lot from these people. Ashim and Ashish have been my teachers. Learnt a lot, and the 6th of September is going to be a dream webinar wherein we all
Wonderful.
four
We
are
all will be
operating.
looking forward to it.
All four are operating
Yes, sir.
and will cover almost every interesting situation of autology, every common situation as well, every informative thing as well. Learning autology from Desai Institute is always a opportunity
Yeah.
that I can never miss.
Yes.
And I am looking forward to it, and I request everyone to join us, and more and more discussion, more and more questions. It's always beneficial. Even believe me, I am the one who learned most out of these webinars. Every day, a single thing I have learned is a day for me. Believe me, there are so many people who are so experienced and contributing. This is something amazing. Thank you, Pachori boss.
Thank
Yeah.
you. Thank
Thank
you
you.
all.
Thank you, sir.
Teamwork.
Thank you.
Thank.
Before we close, sir, once again, before we close, sir, once again, my heartiest thanks to sir because you have given big words to Sun Pharma today, and not today only.
Sun Pharma, we are always grateful, sir.
This comes from your heart, and then
We have bothered you a lot. We bothered you a lot, I would say.
I don't think and whatever.
Always just say that this type of work can
I
only
know.
be done by
They are
Sun
the
Pharma.
one
Even so many companies, the big
who
companies
are
are still.
always supportive to academic activities, I know.
And Dr. Lajandani told me last week, since even nobody comes to his place from Sun Pharma, even they are writing because of they are just.
I know.
And
I
not only
remember.
me, the whole
I
ENT
remember their
fraternity is
event
supporting.
last year with Dr. George Varghese in Cochin. The kind of commitment I've seen.
Yes.
Let's
Yes,
see
sir.
how it goes.
Yes, sir. So we'll continue to, and we'll keep continuing this
But Dr.
support
Pachori,
sermon
it
for
was no
academical interest,
complaint
and
for Sun
especially
Pharma. It
for
Yeah,
was
virtual.
just a compliment to the Sun
Compliment.
Pharma
That's right.
that
Compliment
their
because of.
contribution to ENT specialty in
That's why he
this
said.
kind of conference and webinars will always be remembered.
There are so many people like you.
Thank you.
They must
And
have started
today is the most, the thing which has given me the happiness to the highest level is Dr. Sandeep from Bareilly,
Yeah,
who
he is.
did angiofibroma, the big one. He showed the picture, amazing, and he gave a little bit credit to this webinar. This gives us happiness.
Yeah,
Believe me,
absolutely. And he's
whatever
right.
procedure we have shown, I wish everyone to start doing it. If you have any slightest problem, you can always contact me.
And we
But you
all
should do it.
juniors or
No one
seniors.
is perfect from beginning. Believe me, no one is perfect. If you think you are doing something for the first time and imagining to be the best one, don't think that. You may do the best one, but why to unnecessarily keep a load on your brain? You just
And
keep doing.
we are
In
getting
times to
feedback from
no one
different
in this
people.
world is perfect. No one in this
Yes.
world. I have seen the best of the people who are on the top of the world now has given the worst of the failures, including me.
Yeah.
So it is for everyone. Just start doing. If you have a problem, patient creating problems to you in your practice, this and that, you can offer a free surgery for your learning. What is the
Yes.
harm?
Yes.
If you invest some money for the patient to do free of cost, of course, in
Yes.
your mind, you are very clear about doing everything good to the patient. But at least to get the patient confidence, you do it free. What is the problem?
And
Even a
that's we are
free
No
getting
patient
issues.
feedback from
But
listening
so many
experience,
people.
once you do
it
4 or
goes
5
long way.
cases, you'll be much better. You'll become master. See, money is something different. Never connect with the work you are doing. It will come automatically if you are doing good. But something you have to initiate. I have discussed a lot of people with that deadlock. I have this problem. I have a fear of this. I don't want to start. I am happy doing everything else. Why not? I have seen him doing, not giving the name, but I have seen people doing good work. But the deadlock is the fear. And in a private practice, the biggest fear is now some complication, medical, legal. You know, you can take your patient in confidence. If he's a poor one, is the issue, you sit with the patient half an hour. See,
Yeah.
nobody in the world is coming to the doctor with negative attitude. While coming,
Yeah.
the issue is the lack of dialogue.
Yes,
Yeah.
that is.
All medical legal problems are because of lack of dialogue. I have seen patients, with the experience, I have seen some patients who are not looking good. They have all negative questions in mind. They will discuss with this doctor, and in first scene, you will find this is not a good patient. Better avoid this. You sit with the patient. You invest your time. You show your commitment, and you show ultimately that I can try my best, boss. If you still have an issue, you're free to take your own decision. But at least, those patients are afraid of something happened in the past. Maybe, there are some people, they may have a bitter experience in the past. So ultimately, we have to be positive to bring them to the reality that, boss, this is the reality. Medical science is not complete.
Yeah.
Medical science is, we are learning every day. For
Yes,
so
sir.
many years in practice, still every day we are learning, and there is nothing incomplete. There are so many unpredictable things. You have to understand, you have to bring in confidence, your patient. That's it. That is the end to the medical legal problem. Believe me, lack of dialogue.
And if you
Invest
are
more time.
fearful,
In this era, invest more time to the patient. That is the only answer.
more time, and if you are fearful, call a senior colleague who's always comfortable to bring you up, so you can make a team with them, and then gradually your fears will go away, and you will earn your skill
Yes.
Your
gradually.
laptop is with you right now?
Many of the time, believe me, sir, I'm so fortunate
I
to
have
have
called
some
my seniors
patients
many times.
whom we have given complications. We went in retrospective, looking at the every aspect, then we realized this could have been avoided, you know. But that time was not seeming, you know. And those patients, still we try to cover up, how to cover up the complications. And they agreed, doctor, you do everything, we have a full faith in you. And that time you have tears in your eyes, you know. The
Yeah,
patient having so much of faith in you, in
yeah,
spite of in spite of having given complication to him.
yes,
Everything is not in your hand. You are learning. Everybody is learning. This medical science is never ending. Every day is a new concept. Every day you have to read. And more than that, every patient has a different behavior.
So your laptop is on right now?
Yes, yes.
People are asking for this
Yes.
douching video
Oh, yeah,
facility.
yeah, yeah. Sorry, boss.
okay.
Sorry, boss.
That
Let
is
me
most important
find.
thing.
Yeah, yeah, yeah. Let me
Ah,
We
find
have,
we
out.
should
because we have
wait.
shown almost 20 fast, but
Yeah, yeah, yeah. Give me 1 minute of time, boss.
Meanwhile, once again, my heartiest thanks to the Dr. Jain and Dr. Rajiv Pachori's team for the exposed legend on where Sun Pharma. Before I close this, and once again, I seek the entire medical fraternity's support for our brands too. That is, one is Montec FX, Ripodam XP, Recipe, and BetaVert. So I
Don't
would
worry, we
definitely
remember it
expect
all
that the support
by
also will
heart
be there.
by now.
by heart, people
Yes,
remember
sir.
the
Thank you.
sunflower by heart now.
Sun
Thank you, sir.
Sapodem.
Thank
That
you.
is true.
Thank you.
And
Yeah, Sansipodam, Betaward, Montec FX, sir. Montec FX is another brand where we have been, because we came very late in the market, but still we have come to a very reasonable position in the market. chair and other thing because of the support from the ENT. Yeah. Once again, my heartiest thanks, doctor, and give us more and more
Thank you.
support for us to serve you more and more. Yeah.
Yes, this is the picture.
You know, the biggest person, the biggest applause who deserves. Hello?
The delegates,
The person who is always behind the curtain.
staff, your staff.
Our anesthesia team.
Oh, yeah, of course. They are the.
We have 6 theaters running. We have 8 anesthesiologists, you know. And the guy who's heading is Dr. Anupam, taking care of every patient with the central monitoring, this and that. There's so many alarms going on. But this is something commitment. Majority
That's
of the
good.
times we have all 6 theaters on. Of course, 4 are GA and the 2 others are going on with all these small things. But on. And the biggest thanks to our anesthesia team. Now, are you getting any picture?
Yes, sir,
Yeah,
we're
we
getting
get
it. We're getting it.
See, the aim of sinus surgery, you know, majority of the time it is eosinophilic disease. Majority. And the goal of surgery is to allow the steroid to reach to the depth of all the sinuses, to the mucosa of the sinuses. So, what is the role of surgery? To remove all the inflammatory load. Like in this fungus, we remove the antigen, which is the fungus, which is giving all the problems, recruiting eosinophils and giving all the issues. So the role of surgery is to remove the antigens, remove the load, inflammatory load, and then allowing the steroid to reach to the depth of all the sinuses. You know? So the main goal of surgery is to allow the steroid to reach to the depth of the sinuses. And to achieve that, we have to instruct patient post-operatively to douche with the steroid solution in some particular position so the steroid should reach everywhere. What is this? You know, this is you know, the second position I am going to show you.
Namaz position. Yes.
That this one, this we have modified, is like in a prayer position. You bent on your knees onto the floor and bring your head down to the floor, like prayer.
Okay.
And you know, once you douche, where the solution is going to be, your frontal sinuses become dependent. Now, the biggest problem is you douche in any position, in a normal position. Your solution will reach in maxillary and the frontal, but difficult to reach in the sphenoid. Even it is difficult for the surgeon to reach in the frontal because it is so strategically located, difficulty in anterior-superior position. So you have to bring in the anterior-superior to the down position to make it gravitationally, you know, favorable position. Now in this position, when you douche, your solution goes freely into the frontal sinuses. You can see?
Yeah,
Yes, sir.
yeah.
And you know, let me tell you out of the what this thing. Last week we had a huge discussion with Mr. Amit Bakshi from Eris.
Paris.
They are bringing in povidone iodine 0.5% solution in the COVID era for douching. Douching not only sinuses but the nose and nasopharynx to reduce the viral load. It is the viral load in the COVID era which is troublesome. It has taken a
will it-
toll of more than 200 surgeons.
They should rather bring a spray in it rather than duty.
Boss, spray will not penetrate the sinuses deep.
Okay.
The sprays do not cross more than anterior 1/3 of the nasal cavity, sir.
Oh, yes.
They are
But
coming with
powerful.
a solution of 0.5% povidone iodine, reaching everywhere to reduce the viral load. That's a good philosophy. So here
Yes.
what we want, our solution, steroid solution should reach everywhere. So this is one position for the people who cannot go to other position for their spine and other regions, the age and other things. This is one. The second one, to me, we train all young patients in this position. This is head down forward. This is typical prayer position. This is done by everyone easily. Bend on your knees and bring your head down to the floor. Now you look at the angle. You douche, you push anything, it is going to go to the frontal first.
Yes, sir.
That is what we want.
Yes, yes.
Simple. I told several times, umpteen times I have told, we train our patient after the surgery when we remove the pack, we discharge next day. To train them to douche in a particular position so that they can do at home properly. If the patients don't douche properly, whatever work you have done is going to go to a failure. So your, integrity, your whatever work you have done is at stake. So this is how we need to train our patients.
Yes, sir.
Yes, good.
Any other thing?
I think
Udbhav, thank you for bringing in good questions.
No,
he
sir.
is the
Most welcome.
Satish, will you do immunotherapy in these cases, allergic fungal sinusitis later?
Always we try, sir.
Okay.
We send them after 6 weeks.
Okay.
We do a
To
skin prick
allergy.
allergic testing
Mhm.
after withdrawing everything, every medication. Skin prick allergic testing, and many a times, over I would say 60% of the situation, we have been able to find the causative fungus
Sir,
and then subjected to immunotherapy. Not always.
Sir, Dr. John Shadow saying from Australia, I did my first acoustic neuroma surgery after avoiding them for so many years just because after watching your webinar.
Yeah, he did last month. He did last month. Yeah.
Again, he is giving us so much of happiness. That is our goal.
Yes, sir.
Thank you, Dr. John Shadow, and keep it up. If you can do acoustic, you can do everything, boss. Otology and rhinology, they run with the same concept. Anatomy, 3D anatomy, the understanding of the aeration concept, and final, exteriorization, irrigation, all those things. Almost same concept.
Yes, sir.
Ashish Bhumkar always says, if somebody can do otology, understanding the concept of aeration can do rhinology as well. If somebody is so reserved that he doesn't do rhinology, he can do otology, the concept is different. It's never a different concept. It's always same. Lal Chandani sir, thank you so much.
Thank you all. I
have no words to express.
One more point about Dr. Lajchandani sir. I did my MS from Kanpur. So many students have done MS from Kanpur, and all those who have done MS from Kanpur must have visited his place. I visited his place. I learned so many things during PG from his center.
Thank you. Oh, you make my day. Thank you so much. My center is always open for everybody to come and see.
We used to go to his place during MS time and used to
Thank you. Great, sir.
last
Great.
year.
Thank you, Rajiv, for remembering all those.
I always remember Dr. Sethi because his contribution to our teaching every time. What we are today it is his contribution which is a major one in understanding rhinology concept, endoscopic sinus. This is something you cannot, bring out of your mind. This is something really which has made what you are. You can never forget.
Yes, you are right. Dr. Sethi inspired us all. He was a kind of new entry into the scene of Indian ENT doctors with his very aggressive endological practices. He inspired us all. We all have visited his. It was Singapore was kind of mecca
he
to
is
us
always supportive.
for endoscopic. We always remember.
He is always supportive.
I had a
In his
short stint
hearts of
with him.
hearts, is truly like what we believe, what we see, what a Sardar is going to be. You know, always happy. Singh is king is
Thing is
exactly
king.
like that. Always supportive, always is a party guy, is always
I think
something like
after a hard day's
he
work,
is above all.
always after a hard day's work.
He is above all, believe me.
He enjoyed the day after hard day's work. I
Yes,
remember
yes, yes.
all time was different, but working time was different. He was different person when he was working
He is a
in the
big heart.
operation theater. He was different,
Simply, I
large heart.
can say he has a big heart.
And
Teaching
he
students and being happy with what his students are
father
doing
to many
is something
Indian
rare to
surgeons,
see.
father to many Indian surgeons.
Rare to see. So, sir, once again, I
Thank
invite
you.
you all for the next webinar on 6th of September, as we don't have a session on 30th because of some regions we have family functions. But 6th of September is our dream webinar with our
Yes,
all
sir.
brothers operating together and covering everything about autology, every possible thing, important thing. No, we know the autology is
Will
so
be a day to
vast.
look up forward.
Every important thing we'll try to touch upon. Thank you.
So
Okay.
let's call it a day and good
Thank you,
night
sir.
to
Yeah, yeah.
everybody.
Thank you,
Thank
sir.
you.
Thank
Thank
you.
you, Dr. Satish, Dr.
Thank
Pharma, Udbhav,
you, sir. Good night.
Ansani
Good
sir,
night. Good
Dr.
night. Good night.
Thank
Udbhav,
you.
great.
Thank you.
Thank you.
Good
Thank
night,
you,
good night,
Satish
good
sir.
night.
Thank you, Rajesh sir. Thank you.
Good night.
Thank you. Thank you. क्या हाल है